position where they are coming to the country not because of cost, but because of the quality of care which we are giving them. Awareness building has led to increase in demand. So community outreach program, TV, digital media, and there's this More Joy campaign. So I was on the board of IFFS for 9 years. So just like FIGO is the mother body of all of us, the infertility group, the mother body of infertility is the International Federation of Fertility Societies. Of that I was a board member, and they have the More Joy campaign. So you can go to the IFFS site and pull out this superb campaign it is. You must all go there who are doing IVF, pull out this literature and use it to promote it on your own Instagram site, digital sites. It is free to everyone. And this campaign, similar, the FIGO should start, where they give all this information which you can use in your own digital space. And new areas keep up popping up. So we have fertility apps, new therapies are coming up, artificial intelligence, automation in the lab, like robotic XC, time-lapse imaging, dynamic cell cultures, which I will just talk to you in a very quick way. So what is the new thing in the sperm? One is the automatic sperm analysis. So all our IVF groups now in all the centers have got automated analysis. In the olden days, it was very costly. It used to cost 30 lakhs. Now it is just, there's one machine which costs 1.5 lakhs, the other one costs 5 lakhs. It's superb. We put a drop, automatic cloud computing takes place, and automatic, the advantage of these systems are that it will tell you whether you should do IUI or you should do IVF. So by using the final outcome, the system will tell you, based on what is known as total motile sperm count assessment, you can decide whether you should go for IUI or IVF. So in fact, this same system has to come, Dr. Rohana, in cesarean. So we have to put inputs into an artificial intelligence system, and the computer has to tell you whether you go for a cesarean or a normal delivery. This is the vision, so that tomorrow litigation will get eliminated, because we'll feed it in the computer and decide based on complications. So the same automatic decision making as to what direction to do the therapy is very important. Then we have the improvement of semen preparation. So this is the new cartridge that has come in. It is a fantastic microfluidics. You just load the cartridge, and just within 40 minutes you get the sperm. They're all double density gradient, MAC, swim up, everything we have eliminated in our group. It's a but everything that you do to give quality, it costs cost. The cartridge is 5,000, 6,000 rupees. So, but remember, quality doesn't come at someone has to support quality. Either the government has to subsidize it, or you have to take a hit by reducing your charges. But as I told you, never compromise on quality because the patient is poor. You must remember that all the time. So that, of course, the other thing that has come up very largely is the new breakthrough. It's just recently, 3 months back, it has been shown now. So automatic, so in non-obstructive azoospermia, we pick up the testicular biopsy, automatic, and we look for the sperm in the testicular biopsy specimen. New program has come of artificial intelligence. The machine tells you where the sperm is. Otherwise, it takes a lot of time. It takes 2-3 hours to search for the sperm. Machine based on morphology and motility will exactly take you to the site where you can see the sperm and pick it up. So that's a big breakthrough that has come. The other breakthrough that has come is what is known as the automatic ICSI. So if you see on the right hand screen, which you have that, the machine will analyze. As you are doing the ICSI, where you connect to the server in United States, and the machine tells you which sperm to pick up and do the injection. So what is known as, based on artificial intelligence, the motility and morphology of the sperm, you can actually pick up the sperm and inject. You also have what is known as spindle check. So while doing ICSI, you can actually see the spindle and do the ICSI. So this is a fantastic technology, and especially in patients what is known as for spindle transfer, we can do it. The another technology that has come is you can use now freeze single sperm. So in the olden days, we could not freeze and recover single sperm, because in patients of non-obstructive azoospermia, what happens is that many times, if you do 10 specimen analysis, only one of them you may get 1 or 2 sperms in a centrifugation sample. So how do you recover this sperm? So now this is called the sperm vitrification device that has come, and it's very good. Then of course, the new mind-boggling technology that is coming up is the generation of sperms from skin cells. So this technology has developed in China and in Japan, and already mice have been born out of this technology, and the human work has started. So in say 4-5 years time from now, if you are a azoospermia or you don't have eggs in your ovary, you can take a skin biopsy and freeze it and send it by courier to Japan. They will, in the bioreactor, create the sperms of the oocyte, they'll freeze them and courier them back. It may cost you $50,000 or something, but technology is, parallel technology. I would like to tell you that there's some cancer treatment technology that has come in Zurich for lymphomas. It is costing 4 crore rupees, CAR T cell technology. There is a waiting list of 3 years for that technology. So the technology that is so reprogramming the skin cells is going to be the future. So in some time, maybe 10 years down the line, because you know how Indians are, they'll copy the technology and make it very cheap in India. So 10 years time later on, you may not take out eggs, you'll just create the eggs out of the skin biopsy, and then the ovum pickup may go away from. So as far as the ovary is concerned, ovarian oocyte freezing, ovarian tissue freezing, all that is very now prevalent. I don't have to talk to you about it much. You can do, but one thing I wanted to show you is that you can do artificial intelligence on oocyte. So now what we have got, so after we freeze the oocyte, the question is always, doctor, how many eggs should I freeze? Now we have a technology, since last 3 years I am doing it in my unit in Lilavati and in Delhi. We can export the photo of the oocytes to Canada, and there's a server in Canada which tells you whether these eggs are enough to give rise to a pregnancy after 7 to 10 years later, based on just the image of the oocyte. So poor ovarian reserve is another big thing. As I told you, I have started doing stem cell PRP injection. Last month I have done 5 patients already. So we take it out from the bone marrow. There is a separation, simple. It is a simple device. You need a centrifuge, which is a cold centrifuge, because you have to maintain the stem cell at 24 degrees centigrade. You separate the stem cell and you inject it. Normally we inject them by laparoscope rather than by vaginal ultrasound. So this is a new technology. It gives about 10-12% recovery. I tell my patient, it's a horrible technology, please don't do it. But many of the patients, they don't want to go for donor egg. They hate the concept of donor egg and they will never accept it. The other thing that I wanted to tell you was the embryo selection technology. So we normally select the embryos by naked eye, but now we can do, of course, genetic testing of the embryos. But the thing I wanted to show you was the embryoscope. You can just do video analysis of the embryo. It's a superb machine which we have got. I've been there having it for the last 12 years. And now the new machine has come with artificial intelligence. You can just select the best embryo and transfer it, and you can get a fantastic result. So the ranking is there. The other thing that is very much hot is correction of the embryos using CRISPR technology, which many people have started doing, but the embryos that have been corrected, they have not been put back. As such, as they are, there is no permission to put back these embryos because we are worried about the abnormalities which are there. The final thing is the endometrium, and the ultimate thing is the transplant technology. But in the transplant, there was a problem, and so the now the cadaveric transplant has come in. That has really become, because transplant from a live donor, you could have always, the donor can die. So that cadaveric transplant is a big breakthrough. So whatever the other thing that has happened, I'll just take 2-3 more minutes. There's an increase in parallel work. So expanded carrier screening, PGT for monogenic disorder, PGT for polygenic disorder, fertility preservation, ovarian rejuvenation, uterine transplant, biotechnology, gamete creation. So new technologies are growing because of this parallel work that has gone up. And if you look at this, this is the new market survey that has come worldwide. This is the global in vitro fertilization market. Of the survey has said that the market is $23 billion and it is growing at a CAGR of nearly 16%. And the Europe, North America, and mainly our Asia has a growing, fastest growing market in the world. We are having nearly 25% of the market, and the Indian market is $1 billion US in 2024, and it will grow to $5 billion US by 2033. So we are in a fantastic growth curve. And in conclusion, standardization of care has increased the pregnancy rates in IVF. There is an increase in ancillary services. Regulation and compliance has consolidated the specialty. Minimizing complications has improved consumer confidence. Participation of NGOs and ministries has enabled health equity. Ethical clarity has increased utilization of services. Medical tourism is propelling our economy. Awareness has led to increase in demand and increase in supply. Awareness, availability, advocacy, affordability has improved access. New indications, innovation and research will contribute to success, and improving profitability has attracted investment and growth. Yes, ladies and gentlemen, the future of IVF is very bright. Thank you very much for allowing me to present myself. Thank you.
I request the chairperson to hand over the memento to sir. I request Dr. Swarna to the stage to receive her memento.
Hello. Yeah, it's working. So that was an amazing talk, sir. Actually, we need some changes in the law to make IVF more practical in our country, sir. So the setups are there, but the laws are very stringent. And anything new, sir, regarding the laws?
As I told you that next year I will start working on the changes, but there is what is known as a 2-year window given by the government. Once the 2-year window is over, it may be difficult to change the law. So we will have to go to the minister, and there are some minor, otherwise we are very happy. Our units are doing very well. There is only the surrogacy. There is one problem of imprisonment is there, but then if you look at the MTB law also, or the POCSO Act, there is imprisonment. So I don't think you should get scared of the imprisonment clause. My only problem is with the donor compensation, which is again not there. So that is one area where we can be the compensation clause is not there only in the new ART bill. So we'll have to bring in that clause, which is the main thing. Once we do that, India is rocking. There's no way looking back. We are still already on the growth curve now. Yeah. Thank you.
Rishikesh, it was an excellent delivery as usual, and I must say that I had opportunity, and now also I'm having opportunity to work with Rishikesh. I was secretary to him, and of course in the administration we were together, and we know each other since last 30 years. And he's an excellent worker. Innovation, he always get innovation idea, every time, and he implement them. That is Rishikesh. I also get so many ideas, but we don't implement. So he is the one who implement for the betterment of women. And nowadays the way he talked to us, gave the talk, we feel now each and every lady who desires to have pregnancy will definitely become a mother. So that is boon to our society and everybody. Thank you, Rishikesh.
Thank you. Thank you very much.
I request Dr. Akila Ayavu to the
Hello.
dais.
Hello. Good morning to everybody. Now our next speaker is Dr. Ahila Ayub. She is no other than our great Shamila Vice President sister. And I'm very happy that sir, their father is sitting over here and blessing them. He has always blessed, and so nice to see father over here and all sisters around. So with this, I would like to say she's a consultant in pediatric endocrinology and diabetes. G. Kuppuswamy Naidu Memorial Hospital, Coimbatore, India. She is Honorary Research Fellow, Liggins Institute, University of Auckland in New Zealand. She is a President of Indian Society for Pediatric and Adolescent Endocrinology 2023 and 24, and her special interests are subcutaneous insulin in decay, pediatric lipid disorders, and she had many awards. The important ones are the John Funder Prize for the Best PhD Student Research Publication in 2013, Liggins Institute of New Zealand, and publication. She has multiple publications in GCEM, American Journal of Obstetrics and Gynecology, Clinical Endocrinology, Journal of Pediatrics, Future Cardiology, Journal of Endocrinology Society, Indian Journal of Pediatrics, and Indian Pediatric. So Dr. Ahila, the stage is yours.
Thank you. Good morning, ladies and gentlemen. Thank you so much, madam, for that kind introduction. And it's an honor to be in front of the teacher of Charmi. And also it's an honor to be in front of Dr. Jayam Kannan and my dad. And I hope my dad enjoys, he listens to everything and then he'll come and criticize me after this. Thank you, Dr. Umayal and the chairpersons for this kind introduction. I know I'm completely taking you away from obstetrics and gynecology because some of my thoughts may actually be counterproductive to what you were thinking, which includes the last slide on uterine transplant. As a pediatric endocrinologist with a huge number of children with MRKH syndrome, which we see, and I've got about 80 children with Turner syndrome, we are against uterine transplant. We always think the children and their life as a future person, as a human being, is much more important than having a child. The child you have, even if you adopt a child, when you take it into your heart, it is your child, and we actually don't look at compromising your health for pregnancy. So I think I'm actually against the last slide, and I wanted to say that before I started my lecture. So you have puberty, precocious puberty, which usually goes to the obstetrician for the first consult. Secondary sexual characters which appear before the age of 8 is called precocious puberty. It could be true, it could be pseudo, it could be central, it could be peripheral, it could be isosexual, or it could be contrasexual. So premature puberty, the first one is innocuous, but not as always you think. If a child is born to a mother as a term SGA and the mom has history of polycystic ovarian disease, a child with premature puberty, which is innocuous, actually heralds or indicates that this child is at risk for PCOS later. So there are factors which you can modify in your life, and there are factors which are beyond you and you cannot modify. So modifiable risk factors include early institution of lifestyle modification to stop your progression from precocious puberty on to PCOS. So that is an important point for innocuous precocious puberty. But the next one has been accompanied by the enlargement of clitoris, which actually will make you think of CAH and related disorders, or it could be as severe, or it could be mind-blowing. This child had developed adrenarche within a span of 1.5 months, which is adrenocortical carcinoma unless proven otherwise. So it could herald something very simple. It could herald something which is going to appear in later life. It could herald something which is going to happen in the near future, or something which could compromise your life. So please look at it in all in its wholesome view rather than looking at it from a single viewpoint. Premature thelarche. So you know puberty has 3 different sections. You have thelarche, you have puberty, and then you have menarche. They can all go in consonants or without consonants, and each of them have a different reason for being consonant or inconsonant. So this is a premature thelarche. The first one appeared due to precocious, it's actually early puberty changes in the first 6 months of life, which is mini puberty of the young, which caused the enlargement of the breast, but there was no progression. The second one was a functional cyst of the ovary, so the breast came, it subsided. It came, it subsided. So again, if you have only one episode, you just keep a watch. If it keeps appearing, you have to watch out for McCune-Albright syndrome or G protein coupled receptor mutations in the ovaries, which could herald something different, and this can lead on to several other changes both in bone health and reproductive health. So the next one, this is a girl with just breast development, and had a huge pituitary enlargement, but she had dry scaly skin, which is probably visible on the screen, and this was a premature thelarchy due to a pituitary mass. So this was referred to us as a pituitary tumor, but when you have puberty, remember estrogen is the most important hormone for the development of bones and the progression in growth in the bones. So if you have huge amount of estrogen, you should be taller than your peer, but this girl is shorter than her peer. So this is a girl who came for respiratory tract infection. So this indicates there's something which has compromised her height in spite of the estrogen, and then that means it is hypothyroidism. So she had a huge hyperstimulated ovaries on her ultrasound, and she had no pubic hair, and this was precocious puberty due to autoimmune hypothyroidism. So this is another of our children who had lost her one of the ovaries because after untotting they could not re-establish blood supply. Dr. Suman Nadarajan madam was a part of the team which operated on this, and then now she's subsequently well, she's married and she's got children now. This is a boy who also had a similar picture in his testis. So this is Van Wyk-Grumbach syndrome, which is ovarian hyperstimulation, and here the TSH has a huge amount of similarity to your FSH, but why would only a few people develop ovarian cysts and why wouldn't the others? There is probably an underlying mutation which makes them more sensitive to the effects of TSH. So we've got the biggest series in the world, and we published it last year in Journal of Endocrine Society, where 30 children with Van Wyk-Grumbach syndrome, and I think I already have about 15 plus in my own clinic. So this is another peripheral precocious puberty due to a juvenile granulosa cell tumor of the ovary. This is again a breast development in a 1.5-year-old child. She had a hypothalamic hamartoma, which was innocuous, but that was the reason for her precocious puberty. She was treated with GnRH agonist until 11.5 years of age. We stopped and she went through normal puberty 6 to 18, I think about 10 months later, and it usually happens 6 to 18 months from stopping of GnRH analogs, and then she is now growing well and she's going to get married in the recent future. So you know that the GnRH is secreted in pulses from the hypothalamus, which releases the LH and FSH, and which stimulates the ovary and induces puberty. By giving analogs, we actually downregulating the GnRH receptors, decrease the hormone and suppress puberty. This actually, we reassure our patients that the leuprolide depots have been in use for more than 40 years, and there are not much of long-term complications. You remember it is supposed to reduce your bone mineral density, but the maximum bone mineral mass accrual happens during puberty, which is just postponed, you're not stopping it. So when they go through their puberty, after you stop your GnRH analogs, they will still manage to get their bone mineral strength. So it is okay to treat in children. The only worry we have is abscess, because we have some children who are prone for abscess from the site of leuprolide depot injections. We have not been able to import histoline implant in India. Again, decapeptyl is not very easily available for us, so we are still stuck with leuprolide depot. This is a child with breast development who had her first period at 1 year of age, had been going around different consults, and then this is a marker, and this is a clue. This is a huge Caffelet spot with coast of main appearance, and she had McCune-Albright syndrome. So what do? We start with tamoxifen to block the receptor effect. I always use tamoxifen because I'm much more happier with the bone mineral density we accrue with tamoxifen with this, because this is a long-term use, and they still break through on tamoxifen, and then I start letrozole. But I have not used fulvestrant yet because it's quite expensive, but it is recommended as a 28-day injection. After a year of tamoxifen, she stopped, and then actually she went through normal puberty at 10 years of age. Your progression of bone lesion and the ovarian cyst actually becomes a little bit less after the stop of growth. So this is a slide from my friend Anurag Bajpai from Kanpur. You look at precocious puberty in 3 aspects: thelarchy, pubarchy, and then menarchy. If it is isolated without breast development, then it's only a local reason. If you have pubarchy, can or cannot be in consonance, need not be in consonance. So you always have to look at isolated pubarchy differently. When you have thelarchy, then you also consider it to be a part of complete pubertal progression. If the bone age is retarded, it is hypothyroidism. If it is normal, then we think of slowly progressive variant of normal puberty. If the LH and FSH are high, then you consider it to be a gonadotropin dependent or a gonadotropin independent cause of precocious puberty. This is a slide I don't think you all would have a opportunity to see. This is one of my children who has a 46XX congenital adrenal hyperplasia, was brought up as a boy, who was very clear that he wanted to be a boy and he chose to be a boy. They had refused treatment. When you have huge amounts of sex steroids floating around in the circulation, it can stimulate your hypothalamus and initiate true central precocious puberty. So he developed breast development at 8 years. He also had external genitalia which was almost near normal male, and then we actually treated him with GnRH analog till he got a little bit of growth. He had a mammoplasty and a hysterectomy because he went through a committee which looks at disorders of sexual development, and they give their approval before surgeries, before life-altering surgeries. And then he had mammoplasty and hysterectomy, and he was started on lifelong testosterone, and that is him a month ago. So he is a happy boy. He wants to enter medicine. We'll see whether he makes it or not, because I think life was easier than doing UG NEET for him. 16-year-old girl, she's worried about absence of pubertal structures, and the mom is a nurse in our own hospital. So somebody had told her, you can have your puberty at 18 years. You just walked in and my diagnosis was Turner syndrome. You don't have to have external markers of Turner syndrome to diagnose Turner syndrome. Short stature is the most important clinical feature that is present in every child with Turner syndrome. So she is shorter than both her parents. Her mid-parental height was far ahead of her. She is a Turner syndrome, and then she went through treatment. So you have primary amenorrhea, you look at the breast. If it is delayed, then you look at the FSH. If it is low, it is hypo. If it is high, then you think of the gonadal dysgenesis. If the breast development is normal, you look at the ultrasound of the uterus. If it is present, you will look for abnormalities in the uterus or the ovaries. If it is absent, then you look at androgen insensitivity syndrome or developmental defects of the Mullerian duct. So these are two girls who had come to my clinic. The second one, I think, is the only patient who has ever been referred to me by my husband, who is a neurologist. We don't get along much profession-wise. So he actually sent this child because this child had come to him with repeated convulsions. They had missed huge amount of history in the antenatal. She delivered. This child went through several recurrent episodes of hypoglycemia in the newborn period. She had prolonged physiological jaundice. The prolonged physiological jaundice is it's an important indicator of hypopituitarism. So she had recurrent hypoglycemia because of growth hormone deficiency. She had prolonged physiological jaundice because of central hypothyroidism, and actually she came to me because of delayed puberty. She had all her 5 anterior pituitary hormones had gone for a 6. So she had reduction in her growth hormone secretion. Her TSH was deficient. She could not tolerate temperature of more than 100 degrees Fahrenheit, which is an important indicator of ACTH deficiency, and she also had absence of puberty. So all her 5 hormones had gone. So you should remember, before you replace hydrocortisone, before you replace thyroxine, you should replace hydrocortisone. If you have a stress, you can actually fail and you can collapse and you can lose the patient to hypotension and hypoglycemia. So cortisol supplementation takes precedence over all other anterior pituitary hormones. So she went on hydrocortisone replacement first, then thyroxine replacement, then growth hormone therapy. Then after achieving certain amount of growth, then she needed sex steroid replacement because she did not go through spontaneous puberty. So definition of delayed puberty: absence of breast budding in girls beyond 13 years of age. You should definitely ask for delayed puberty in family members, which could indicate constitutional delay in growth and puberty. It is much more significant in boys, but it is still significant in girls too. The growth pattern, chronic illnesses including psychosocial deprivation, congenital abnormalities including anosmia, visual defects, midline defects, headache, seizures. So 30% in girls could be due to constitutional delay. Hypo can be due to organic, syndromic or chronic disorders. Hypergonadotropic hypogonadism due to gonadal or syndromic classes. So this is one of the girls who came to me again with delayed puberty, dry scaly skin. Your TSH will be normal. don't ever do a single TSH to look for hypothyroidism. You will miss central hypothyroidism. The TSH will be normal, but your T4 and free T4 will be low. So that is central hypothyroidism. So she had been missed because huge number of people had kept on looking at only TSH. TSH is high only in primary hypothyroidism and not in central causes. So then she went through thyroid replacement. This was another girl who had delayed puberty. She was tall and she walked into my clinic. You cannot be Turner's. What else could you be? She again had MRI of the abdomen, she had ultrasound, MRI, she had huge number of investigations, but nobody looks at her external genitalia in depth. She actually had an androgen insensitivity syndrome and there was a palpable gonad in the labioscrotal fold. So the diagnosis is, helps you decide on what management you would undertake. Remember again, nothing is foolproof in this world. So this is all of you know, this is a 45X Turner syndrome chromosome. But what is this? This came to me as a normal chromosomal report. Remember, your short arm of the X chromosome has a huge number of functions. When you have iso-Q, one of the X chromosome has two long arms. So this is an iso-Q Turner syndrome variant. This will behave like a Turner syndrome. Just because you have 46XX does not mean you don't have Turner syndrome. So Turner syndrome is complete or partial monosomy X, isochromosome or ring chromosome or mosaics, occurs in 2000 to 5000 females. You also have to remember the X can come either from the dad or from the mom. Again, avara pota avarada molekkum, tavara pota tavarada molekkum. For whoever of you who can understand Tamil, if you plant a bean seed, you will get a bean plant. If you plant a coconut, you will get a coconut tree. So depending on the inheritance, what you got and where you got your X from, your clinical features will differ. So this is a girl who came to us in Charmi's clinic with delayed puberty. That is her 8-year-old sister and that is her 6-year-old brother, and she's shorter than both of them. She was a typical Turner syndrome. She also had alopecia areata. This is a girl with completely normal phenotype except for short stature. She too had Turner syndrome. So we start growth hormone therapy in short stature. You don't need a growth hormone stimulation test to use growth hormone, but for purposes from the government, when they receive free growth hormone, you have to do a growth hormone stimulation test. For gonadal failure, the best is a transdermal estrogen, because quite frequently Turner syndrome children also have liver dysfunction, and then when you start your estrogen, there can be alteration in the liver function further. So I always have a baseline liver function before I start estrogen. Transdermal estrogen, because it bypasses the liver in the first pass, it usually is much more effective and much more safer in children with Turner syndrome. We prefer transdermal estrogen, but it's quite expensive. We cut the patch into 1/16. We start off 1/16 twice a week and then gradually step up over every 3 months, so that you give enough time for the uterus to grow. In case they want to have pregnancy, remember they can have accelerated hypertension during pregnancy and can tear their aorta by dissection of aorta. You have to explain the risk factors before they trial on a pregnancy. And then we go ahead with thyroid for appropriate medication, and remember bone mineral density. So even if they never want to have a child, estrogen is extremely important for them to maintain their bone mineral density. Long-term data on the evaluation of insulin resistance, risk for breast cancer and other cancers are still lower or is almost as equal as the rest of the human population. So there has not been increased risk because of use of estrogen in these patients with Turner syndrome. So we have a 15-year-old girl. I've got 2 more minutes left, yeah. So this is a girl who's born term SGA with a birth weight of 1.9 kilograms. She attained menarche at 10 years of age with irregular periods. She's worried about her dark, thick facial hair. She's depressed and refused to attend school. Mother has similar facial hair but of less severity. So this is the girl with severe acanthosis nigricans and a severe variety of hirsutism. She is obese. Her BMI is 30.6 kilogram per meter squared. Please remember the Indian cutoff for obesity is 27 and the cutoff for overweight is 24 to 27. It is not the same as the international population. The risk for metabolic syndrome in the South Asian population is huge compared to the rest of the world. You can't compare the rest of the world. So our cutoffs are much more lower, and you have to think of central adiposity. Toppa is a big risk factor for metabolic syndrome. So whenever people get married and then go to their father-in-law's house, most men come back with an abdominal adiposity and a risk for diabetes. So acne, skin tags, and then severe acanthosis. So all of you know about Ferryman-Galway score. You also remember the Ludwig score for androgenic alopecia, and then you have to have thick, long, medullated hair of more than 5 millimeters and more than or equal to 9 in number to first classify them as hirsutism. So remember, the choice of treatment depends on what the patient wants from you. So these are two different patients. This is a late onset CAH. This is a PCOS, and this is a girl in the UK who chose to be a PCOS model, and she's happy with as she is. Your treatment will depend on what the patient wants out of you. So this is one of my children with CAH who went through all her treatment, has done extremely well. She's just completed her master's and she's going to get married. This is vellus hypotrichosis. This is just body hair. There's no hair in the sexual areas. This is an asexual hair. This is not the same as hirsutism. So the risk for PCOS and SGA is far higher. The treatment is individualized, and then metformin only if you have insulin resistance, oral contraceptive pills with anti-androgenic, progestin, but remember drospirenone will not act on hirsutism. Thank you so much. And this is the same girl, she wears the same earring, and look at the scar. So this is before treatment and after treatment. Thank you so much.
Hello, Ahilya, it was excellent delivery because to the obstetrician, all the girls, whether she's a child or at the pubertal age or afterward, all the mothers get the patient to the gynecology. So by your talk, we are really enlightened on this topic, and will definitely give the justice to our patient and refer to you. So thank you very much for your excellent delivery.
Thank you so much, ma'am. Thank you. It's a pleasure and an honor to be here today. Thank you so much. And best wishes to the Kanchipuram Obstetrics Society. And you've done a fantastic conference, and kudos to all of you. Best wishes.
I would like to ask Dr. Charmila Ayyavu to come on stage.
Charmila? Charmila, you want to get Charmila? Yeah. Get your
A proud father with all his 4 children, girls as doctors, Charmila Ayyavu, Akila Ayyavu, Ramala Ayyavu, and then, who's the 4th one? Ranjini Ayyavu. So 4.
A
So
true
proud
sense of woman empowerment. So the father has done so well with his daughters. Hats off. Really, அதுதான் காலையில இருந்து ரசிச்சிட்டு இருக்கேன் நான். எவ்வளவு அழகா வளர்த்திருக்காங்க பொம்பளை பிள்ளைங்களை அப்படினு. Congrats. So beautiful it was. Oh, thank you. அப்படியே ரசிச்சே பார்த்துட்டு இருக்கேன். Oh, thank you.
from Foxy Community Work, winner of Duffer in County's Merit Scholarship for MD period, Best Doctor Award from Tiruthurai-Pundi in 1999, Lifetime Achievement Award from IMA in 2009, and from Tamil Nadu Engineer Medical University from 2011, Honorary FIC OG 2011, Felicitation in Star Society India 2017, and 2018 Marthuva Mamani Award from Thiruvadurai Adinam. And she has been the guide and guru for so many young obstetricians and also all the Auxians to go into Foxy. Madam is a roadmap for all of us. Ma'am, welcome you, ma'am. We are so honored to have you today. Over to you, ma'am.
Thank you. Thank you very much for your lovely introduction of myself. Yeah. Today, it's a very, very common topic because 80% of the women now are going with fibroids. Can we change the game which we are playing now? Can we tweak the game is my question. Yes, when I say tweak, you all can understand from the last picture what I mean by tweak. This is what everybody did when they came on Friday for this conference, and today everybody is with their hair put as a bun back. Thursday, Friday, everybody was enjoying that. So that tweak, what we can bring out is what I am going to talk about. Now, this is my case scenario. She is Bharati, 22 years. She is just living in a studio apartment. Fundal fibroid, wants to marry, doesn't have any money. What she can do? I supported her with a hand-assisted lap myomectomy. Promptly conceived, went up to 38 weeks, fundal fibroid 8 centimeters, and delivered. And in her delivery, we found no problem. She had a vaginal delivery at that time, that is 20 years ago. So here, it is a question of your expertise, efficiency, energetic control of bleeding points which you are doing. Now, the same similar patient came down from USA. She said she has got only 1 week time and she wants a surgery. So what I had to do? I have to change the game. What I can do? Center for the Robotics, do everything under robotics with Apollo Hospital at Chennai, because Apollo, this is robotics, I can't say that a single doctor unit can possess it. To return her back as she wanted, this was done 2 months ago. Could she have any other method of treatment is a question. That question when it comes, the question may be, because she is there in USA, Myfembree is now an accepted FDA approved drugs, and this drug has been done with trials with SOUL trial, and it is an FDA approved drug which she can take it as just 1 tablet. But having come all the way to India, I said, yes, you can undergo robotic surgery. So probably if the patient is outside, we may advise her a tablet also. Now this is another patient whom I had seen in 1984. That time only ultrasound came. Ultra Mark II showed me a picture like this only, what I could see. You see the size of the uterus, 30 weeks, you see the fibroid. Pressing on the liver, pressing on the gallbladder, not able to breathe. So what should I do? I had to do a laparotomy. You see the fibroid size? She had 30 weeks she came, nearly 8 bottles of blood were given and operated. 5 weeks I put her in the bed. 35 weeks I operated and delivered the baby, and second baby was also delivered 1987 by another cesarean section. 1994, 10 years after that, she had multiple fibroids, so I had to operate. If this patient now comes, will this be a problem in this case? What she had is, at that time there is no FIGO classification. FIGO came only 2011 with Monromer. She is a 20 weeks fibroid, 20 centimeter fibroids of FIGO type 6. What we could have done now is a different issue. We would not have gone at 30 weeks with this diagnosis at all. We would have diagnosed her very early in early pregnancy, at 6 weeks, 8 weeks, or at the target ND scan itself, and we could have dealt with her better. So this case is presented not this because It is a case which is going to come now. Even if it comes like this from a remote part of our country, we should be able to tackle her with these things. Now, third case, he is an army person. His wife has got fibroid. She was given SPRM tablets and he has got 1 lakh insurance totally. And he wanted a fibroid care and IVF. So what I could do? I gave her the medical management and stored the semen, asked him to go back to army, and by 18 months after he gave the semen, we, after the SPRM, reducing the fibroid size, lap myomectomy, she, with the intrauterine insemination, conceived, of course delivered by a C-section only. Now the next case is a known doctor. This doctor was having Marina, and because it was there for 5 years, it was had to be removed. Removed, within 2 months, heavy menstrual bleeding, 3 grams reduction in the hemoglobin. She started looking pale. She was going to conferences. I said, you are looking very pale, be careful. 120 days, the uterus went up to 16 weeks fibroid. And the fear of rapid growth with 4 months made her go for a lap hysterectomy. And you see the number of fibroids and the uterus weight, 700 grams. We know normal weight of the uterus is 50 grams. Now this uterus is 700 grams. So that means a rapid growing fibroid, if it is there with the LNGS system, we have still a limitation. Probably in this case, probably if MyFemry is available in India, we could have tried also. And now another thing which is coming up is the use of statins. We all say after the age of 40, all of you go in for aspirin with atorvastatin. So probably these are the drugs, if you start in the general health care, maybe they are able to help you better also. The long-term outcome of the LNGS, which has been shown with so many trials, has proved that it has got a good effect in the primary and secondary outcomes. However, the patient's conditions are the values that we have to look. Now look at another patient. This patient is one of mine, 45 years. You see the number of fibroids which are noted in the uterus. This was again in 2002 or 3, I think. So see the number of fibroids I have removed, clusters of fibroid and this thing. 20 years, no growth in the fibroid, and she is all right. We all say myomectomy is a procedure which has got its own complications and other things. But myomectomy, for all of you who are not in the urban area, who are in the taluk hospital levels, who think that your hand is good and you have got the patience to wait for the hemostasis to settle down, you are not looking at the watch for the time of your surgery, please consider myomectomy is still the choice, because Alka Kriplani, 4 months ago, she put a video on abdominal myomectomy, who is a big trump beater of laparoscopic myomectomy. That shows that she was at AIMS. Now she has stepped down from AIMS. She is in an area where she cannot afford that sort of a big procedures and care. So your hand, if it is good, you can do all these things. The timeline of the myomectomy is known very well, and now we are having all these robotic assistants and the barbed sutures, all these things you hear in the conferences. Yes, have knowledge, but accept what your situation can give you and do it. Your situation can accept hand-assisted lap myomectomy. There is nothing wrong in making a small 3 centimeter incision in the suprapubic area. After a laparoscopy is put in, take out the uterus, handle the uterus nicely, palpate the fibroids happily, and go out with the surgery. Of course, nowadays after a lap myomectomy, you do not see a fibroid totally. You will be seeing only these pieces, but histopathology is a must for all this. Now I put a video, probably see this video. This is a video of, we have been all seeing about the magnetic resonance outmoded procedure. But now you see this as an in-moded procedure which has also been accepted by many people, and voice is not there. Can you put down the light? So this is the trocar, which is now available for this transcervical and even transabdominal modulation of the fibroids inside the fibroid capsule itself. You just use all these things and you can go with this. You put in inside as we are doing an ultrasound guided biopsy, ultrasound guided ovum retrieval. You can do all these things with these equipments, and probably this equipment should be available with us so that we are able to go to the fibroid and see the fibroid, and the this radio frequency wave go directly to that area, and you see how it is burned.
Continual observation of the ultrasound image and generator impedance will be helpful to achieve a complete and safe ablation.
This is now available in the USA, UK also, probably in India. Probably people like Sunita, Kandilwakar and others will be bringing it soon, this sort of this thing also. So now we move on to the robotics. We know about the console, we know about the patient's preparations, all the equipments which are there available, and we can also, the next procedure which we can do is embolization. We are all worried about the embolization because she is going out of our department and going to the radiology department. Where will she go? She promptly returns back to you only after the embolization. The way we take care of this patient after the embolization, how the gynecologist care the patient, is the best way that embolization proceed very well. 25 years now, many centers outside are doing it. Now you send the patient for embolization, get the patient back, take her proper care. Don't expect the pain to be disappearing after embolization. Pain is more. We have to treat her better for the next 1 week with painkillers. After that it takes 6 weeks for them to come down, and the 18% of the women who had good severe pain means that necrosis is going on very well, and they may have loss of appetite and other things. Kindly do give them a good support, and they are able to come out with it very clearly. Radio frequency ablation 2023 is this paper, not the one which we were talking about the failures and people have even become bankrupt after purchasing that equipment. Now this is just a radiopolar energy. I have shown you how it is being used, and this only thing is, if you have a fibroid which is more than 10 centimeter, at time only do one fibroid. If you have fibroids which are less than 5 centimeters, at a time we can do 2-3 fibroids, because it can be done even as an outpatient procedure. Simple anesthesia is enough. Patient can have a day care and go home back. That means she can come back again. Just how we are doing failed IVF 2-3 times, IVF ovum retrieval, and then 5 or 6 times embryo transfers. Please accept this also as a procedure so far as she is wanting to retain the uterus. So don't think of this failed procedure, think of this accepted procedure which has come now in this way. So the word is zap the fibroid with transcervical ablations. Now these are the fibroids I have shown you, this is the probe I have shown you, and the marcelator also I have shown you, and the procedure has been done, and a lady from USA has given such a good experience detail for about having done experience for more than 25 years, and the fibroids go away very nicely. Menopausal women, are they going to get fibroids is a good question. Yes, menopausal women are nowadays going on fibroids because we are giving HRT. We are giving them at the age of 40 pregnancy care. With all these things, our menopausal women, do not expect them to shrink the fibroid. Allow them to think that the fibroid will continue up to the age of 55, and we have to go on with this. So the surgical procedures which are available are hysteroscopic myomectomy, recovery time 1 to 2 days. Perforation, all these things, venous embolism, all these things are noted procedures, but they are not commonly seen in the shoulder. Laparoscopic myomectomy, recovery is little shorter. Robotic myomectomy is what is equal to a laparoscopic myomectomy. Bowel injury, bladder injury, ureteric injury, all these things are only in the learning curve. and this is not the common problem that we meet with, so need not get worried about these things. Decreasing the bleeding with medically management. Drug of choice for fibroids? Yes, we know about gonadotropins, we know about the antagonist. The antagonist has come in a big way in outside the country, even in India, Relugolix has entered. At Delhi, I think it is available, am I right? Bharati Maheshwari should be able to tell me about it. So, but soon it should be coming down, we should be getting it. The drug which is very easily available for us and to give it nicely is mifepristone. One postgraduate of mine who did an FRM with me has done a work on mifepristone in 2007 at SRMC Medical College when she did her MD. 17 years ago at SRMC, Dr. Usha has guided her to do this work. It is quite a cheaper drug. 10 milligram is enough. About this also Alka Kriplani came and talked in Dehradun conference. 5 milligram to 10 milligram is enough. You can give for 3, 6, 9, 12 months. Improvement in the symptoms, reduction in the fibroid size, quality of life, improvement is 85%. It is also useful before surgery if you want to give. Side effects are not too much. The endometrial changes which we see have never been proved to be histopathologically found to be malignant, and the estrogen significantly increased the average post-treatment value, neutralizing the osteoporosis. Akila Yau was going on crying for your estrogen therapy properly for all the Turner syndrome. Don't make them osteoporotic. So here, also when we give drugs for fibroids, we are also worried about the bone mineral loss. Mifepristone is one drug which you can safely give, and this drug has come into the Indian market again with all the senior people, expert people accepting the drug. I think we also should accept this cheap, effective and efficient, energetic. Only thing is we have to understand it and don't look for papers from outside the country, because mifepristone is not being used outside the country. We have papers from India, we have papers up to 2019, we may be getting some papers by next year. Please look at this mifepristone for your return. And there is also another thing called, if you are treating the hypertension properly, these patients' fibroid growth is going in a reduced way. What a nice look at it, huh? It is called a SWAN study. Sweden has got a big database that is called a SWAN study. Anything you want, you go into the database, collect the details, you will be able to produce a paper. It has got data from 1990 to 2024. And in that, they have looked at these patients who are hypertensive, who had fibroid, and the patients especially on ACE inhibitor, not on other drugs. ACE inhibitor used patients, 48% less likely than the patients untreated for hypertension. Is it not a point? Take-home message, mifepristone, and this one has a good take-home message for our Indian scenario, and the transcervical ablation and myolysis for the laparoscopic surgeons need. Another thing, Duke and this university has done a good work. 2 PhDs in biochemistry and physics has come down together, and they have done an engineering smart therapeutic techniques, saying that fibroid is a stiff collagen tissue. The tissue, if can be degraded by a anti-gel tissue gel, it can definitely be better. You see that liquo gel. This has been put in February 2024. Do you see the fibroids there? And these fibroids have been injected with this liquo gel. Liquo gel is a gel in which the medicine they have not told anything. It is only they said collagenase. The medicine is there. Once a liquid is injected into the body, in the body cell it becomes solidified. Automatically the drug stays in the fibroid capsule and it starts working on the fibroid. You see how the fibroid gets reduced in its size, you can see that. So this is in vitro, they have also seen it inside the uterus, and they have taken out reports from the Duke and North Carolina University. Liquo gel is the one which is coming out. So treatment options for fibroids include drugs, interventional radiology, surgical options in generally. Treatment of fibroids begin with medical care. It need not be a fibroid surgery alone. Minimally invasive surgery is always required before a major surgery. Myomectomy, hysterectomy, open or endoscopic or robotic is a common treatment for these people. These data I have collected is from MDH, who has given details about this, and he has made it very clear. Myomectomy is appropriate for many women. We need not feel that we are not doing proper surgery just because we are doing a myomectomy. And this is the latest evidence on currently available treatment modalities of uterine fibroids of medicine. And thanks that we all have these fibroids with all the treatments, and we still are able to give all these treatments except this Licogel, probably transcervical ablator, which should be coming into us. Thank you very much for your patient hearing.
Thank you so much, ma'am. But the thing is, we know only myomectomy and hysterectomy. All these things are really need this. You were telling some combination of the therapy, and that is also one new thing for us. And then this radio frequency ablation of only the fibroids. That is a very, very good for the postgraduates to take up, and those who are practicing hysteroscopic and robotic surgeries. This is going to be in a good way, and it's a very interesting topic, and you only can do it in this good way, ma'am. Because really I don't know what is there when I was seeing the topic only.
Same thing. The same old.
Thank you, ma'am.
Thank you.
I request the chairperson to give away the memento to Jaimkanan ma'am. We will have a short break for 10 minutes for the oration to start, because other hall people has to gather here. So we'll have a 10-minute short break. So the oration will start by 12:20. Good afternoon, everyone. We move on to the next session, oration. I request those who are outside on the stalls to please come to Hall A. The program will not be wired anywhere. Please ask your friends in other halls also to come here for the oration, please. Good afternoon, everybody. We have been indeed very honored to have you all in the South Zone Vice President Conference, Southcon, organized by Dr. Charmila Ayavu, Vice President, South Zone Fogsi, along with Conjipuram OG Society. Now we move on to the oration session, the hallmarking the South Zone International Conference, Southcon. We have 2 orations scheduled for today and 2 more scheduled for tomorrow. We now begin with the first oration, Mr. and Mrs. Ayavu oration by our Foxy President, Dr. Jaideep Tang, on topic Controversies to Consensus in PCOS. I request chairpersons for the oration to take the dais. First, I invite Vice President South Zone Foxy, Dr. Charmila Ayavu, to the dais. Mentor and past Vice President Foxy, Dr. Jayam Kannan ma'am. Mr. Ayavu, father of Dr. Charmila Ayavu, to the dais. Please, sir. Dr. Ahila Ayavu, sister of Dr. Charmila Ayavu, to accompany Mr. Ayavu, sir, to the dais. Dr. Chakravarti, President of KOGS and Organizing Co-Chair of Southcon, to the dais. Now over to the chairpersons.
May I request Dr. Ahila to introduce the oration, Mrs. and Mr. Ayav oration, on whose behalf we are conducting this. And the oration will be given by Dr. Jaideep Tang, the President of Foxy.
Good morning, ladies and gentlemen. It's an honor, and we feel deeply honored that you have honored our parents. I take this opportunity to introduce both my parents. We are 6 daughters born to parents from a family where female infanticide is at the highest. This community to which we belong has high female infanticide, and my parents managed to bring up 6 daughters. So my dad is a chartered accountant who's had 55 years of experience. He's an ardent agriculturist. I think he reads till about 12 midnight even today. He's thorough with all the chartered accountancy journals and the agriculture journals up to date. He has the distinction of arranging conferences, and he also actually managed to talk to Mr. Sharad Pawar, who was the Central Minister for Agriculture earlier, and introduced crop insurance for coconut earlier in the initiation. He had won elections to Chartered Accountants and State Council and was president of the Coimbatore CA Association. He's known for his fiery speech and lectures, and you would probably see that being reflected in all of us. Can I have the next slide, please? My mom is a first lady graduate in about 32 villages. She comes from a patriarchal family where they don't believe in education of women. He's brought up 6 daughters, and she's always told us, your education is your savior, and that is the way forward. And she's actually kept up with the times, and she told my son, you get married if you want to, you don't want to, don't get married. Life is much more important than marriage, so I think we come from a culture, from my mother who's managed to keep up to trend. She's brilliant at artwork, which I don't think none of us ever inherited. And all her grandchildren have been groomed to think that only education is a savior, and we are proud that this oration is initiated to celebrate our parents, and we are deeply thankful to Professor Jaideep Tang and it's an honor that he has accepted that invitation, and I think there could not have been a deeper honor than you delivering this oration on behalf of my parents. Thank you so much.
Thank you so much. Now I'd like to invite Dr. Jayam Kannan, our mentor, to introduce the orator.
Good afternoon to one and all. It's always a pleasure to introduce a person who is known to us for decades. Jaideep Tank is known to me for the past 2 decades, and D.K. Tank, his father, was known to me for 4 decades. And Jaideep Tank, not because of his D.K. Tank's son, he has come up. He has come up on his own. As he expressed yesterday, how he enjoyed the Dalapati movie, and he was enjoying the Rajani's applause which he was getting. Now, I think for us in the Southcon, the Rajanikanth is Dr. Jaideep Tank. So we receive the great applause which this audience would have given if Rajanikanth was here. And you have also done a marvelous work as a Foxy secretary and also as a president. Of course, he has got his own credentials. He has got so many centers in which he does his IVF work. And a couple of years ago, he was saying that he is going for the 50th time to a center in Uttar Pradesh, Dr. Chandravati, such a senior person. She was having so much of faith in Jaideep Tank that he alone was there to do all the work that is required in IVF. Because she was such a senior, she could not do it. So such a creditable person is Jaideep Tank. His biodata, which has been given as a gynecologist working in so many centers, past chair, has done publications. Everything is something which is phenomenal, and his Ashwini's medical maternity center patients are all really patients who are gifted patients. But now his work is with Bill Gates Melinda Foundation, a sort of improvement of what we have been doing on maternal mortality work, and he is concentrating on the states which are having not this 2-figure maternal mortality of India, having the 3-figure, even going up to 200. So in those places, he is trying to put focus so that their maternal mortality comes down to 45-50. We wish you all the best in that work which you are going to do, and of course, the ART bill cannot forget Jaideep Tank. Over to you for your oration.
Thank you, madam. May I request Dr. Chakravarti, the president of the society, to present the orator with a shawl. Shawl, and my father, Mr. Ayau, will put the medal on the orator. Thank you so much. This citation is presented at Southcon Fogsi Southzone Vice President Conference, the Mr. and Mrs. Ayau oration, controversies to consensus and PCOS, being given by Dr. Jaideep Tank. Dr. Jaideep Tank is a dynamic president of Foxy 2024. He is not only an obstetric and gynec specialist par excellence, but also an extraordinary administrative genius who has redefined the narrative of the federation into one with holistic goals. He has envisaged an innovative 360-degree approach to working in the organization with the motto of coordinate, communicate, community. He has to his credit many unique achievements, initiating the digital elections during his tenure as the Secretary General of Foxy, setting up the Foxy guidelines and standards for adolescent and youth-friendly health services, Foxy statements on cesarean rates, hysterectomy rates, contraceptive implants, ART bill, surrogacy bill, and several other projects. He has been recognized for the importance of language and imagery in bridging the gap of medical jargon and public perception, and set up a cell for the same in Foxy. He has been the past Deputy Secretary of and is now the chair of the YGAA Committee of AOFOG. He's been the past chair, Safe Abortion Committee, FIGO, and he's a consultant at Ashwini Maternity and Surgical Hospital, Center for Endoscopy and IVF at Mumbai, and is a visiting consultant for IVF at many centers across the country. Dr. Jaideep Tang is an independent director on the board of API Holdings, India's biggest e-pharmacy, and his approach towards innovative strategies of medico-industry collaborations have been greatly appreciated. He was awarded the fellowship honoris causa by the Royal College in recognition of his work in improving women's health. His innovative, out-of-the-box thinking is particularly appreciated, and with his astute strategic planning and execution of ideas, he's taken the Federation to a whole new level. His administration has balanced technicalities with soft skills development, that is science with society and veterans with youngsters. We, the organizing committee members of this conference, are extremely happy that is accepted to deliver the Mr. and Mrs. Ayahu oration, Controversies to Consensus in PCOS on the 20th of July 2024. Signed by Dr. Madhuri Patel, Secretary General Fogsi, myself, Dr. Chakravarti, President of COGS, and Dr. Umayal Murugesan, Secretary of COGS. Thank you so much for accepting the citation. Thank you.
So, very good afternoon to everybody. Thank you very much again to the organizers of this wonderful conference, Charmila, Dr. Chakravarti, Umair, Dr. Vijay Lakshmi, the entire KOGS team. Thank you very much for all your efforts in, I think I should have 30 minutes, not 10 minutes. And don't start the clock now. Normally now when you have your own laptop, the big advantage is that the timer doesn't come on the screen. But now with these LED screens, they have figured out a way to put the timer. Let me acknowledge the patrons, Dr. Jayam Kannan, Dr. Rukmani, the conveners, and of course all the Foxy office bearers. We have some past presidents here, Dr. P.K. Shah sir, Dr. Suchitra Pandit. We have the Secretary General of AOFOG, Dr. Rohana, and the immediate past chair of the MFM Committee of AOFOG, Dr. Ratnasiri, and so many of my dear friends. I am delighted to be back at an event hosted by the Kanchipuram ONG Society. Umayal, I don't know whether you remember those pictures. Those were that event that I was referring to, immediate post-COVID. You can see some of us wearing a mask over there. And this was in fact the first event in person that I attended post-COVID. So the Kanchipuram Society is always very close to my heart. And of course, it's also very close to my heart because in a way, as I said yesterday, they did have a bit of a difficulty in their labor and delivery, but they were born with very good APGARs. And it was good they were born with very good APGARs because I was in a way the obstetrician of the Kanchipuram Society because I was the Secretary General at that time. Before I begin the presentation proper, I'll ask you all to, as this plate says, save the date. And I'm going to ask you to save the date for two conferences, although there are many conferences including the Southzone Yuva Foxy, which is coming up. One is of course the showpiece event of the Foxy year, which is the AICOG 2025, where I will, and I don't want to say this, but finally hand over the reins of being President Foxy to Dr. Sunita Tandulwadkar. Sunita, we are looking forward to your year. And of course, the traditional presidential conference, which is to take place in Mumbai. And you will see that we have a very wide range of international faculty who have promised to be there. And the conference will consist of a 2-day very exclusive IVF workshop. And I'm making a point to say IVF as opposed to infertility, because this is going to concentrate on the IVF part of infertility, although other topics will be covered. So if you are interested in assisted reproduction, I would strongly urge you to attend this. There are only going to be 120 delegates allowed to attend. And out of the 2 days of deliberations that will take place, around 90% of the topics will be covered by the foreign faculty who are coming all the way from Brussels for this. So having said that, let me thank and again congratulate Charmila for putting this wonderful conference together, and also for this wonderful idea of honoring your parents with a named oration. Sir, you are so fortunate. Although you have 6 daughters, you are very fortunate to have a daughter like Charmila. It's such a pleasure to work with her. And of course, all the other chairpersons, Dr. Jayam Kannan Madam, my mentor and guide since such a long time, Dr. Ahila, Dr. Chakravarti, Umayal, and everybody in the audience, thank you for being here. And I must say that this is perhaps the first time, Sunita, that we are delivering an oration in the same session. And I must say that I'm looking forward to hearing you shortly. So I'm going to speak on controversies to consensus in PCOS. And we know that PCOS is actually a much debated topic. Starting from the point in time when Stein and Leventhal reported very large ovaries, where patients used to have amenorrhea, and they did ovarian resection, say for example for an ovarian cyst or something, and then they found that those patients resumed menses. So they made an assumption that it was the size of the ovary which had so many cysts in it that was causing a problem, and therefore they arrived at this terminology of the polycystic ovarian disease. If you look at the literature around PCOD, you'll see that the 15-year period between 2001 and 2015 has seen more than 20,000 publications on PCOD. I really can't imagine any other topic in gynecology which singularly has contributed so much to the literature. If you look at this graph, which talks about the number of publications year on year published on the topic that is being searched for in Medline, you'll see that the graph has risen quite exponentially. And there does not seem to be any end in sight on what the literature is going to talk about PCOD. In fact, I have often felt that although PCOD means polycystic ovarian syndrome, it should perhaps mean polycontroversial ovarian syndrome, because the controversies around PCOD just don't seem to be ending. And a part of the reason for the controversies really is the way guidelines are written in polycystic ovarian syndrome. There is some confusion about the guidelines on PCOD, and that's why I thought it's appropriate to first present a guideline to the guidelines. It's like presenting a checklist for checklists, given the high number of checklists that we are dealing with now. So in fact, one of the first guidelines that came was the NIH guideline, and what I'd like to point out here is that this NIH guideline was essentially based on a consensus questionnaire. And this is the way guidelines used to be all right to do once upon a time. It used to be 20 people sitting in a room saying that I think this should be okay, and that's how the guideline used to come out. Then we moved on to slightly more robust guidelines, and then the Rotterdam criteria were evolved, where the Rotterdam ESHRE ASRM workshop, and again this was concentrating more on diagnostic criteria and long-term health risks. Then the Thessaloniki workshop came out for infertility treatment, and then the Amsterdam workshop came out with women's health aspects. So till then we had the NIH guidelines, which were general guidelines. We had the Rotterdam diagnostic criteria and long-term health risk guidelines. We then had infertility management guidelines from Thessaloniki and the Amsterdam guidelines, which talked about the women's health aspects. But we didn't have a single overarching guideline on how to best treat and manage infertility. And I was therefore delighted when these guidelines came out. And look at the robustness of the way these guidelines were formulated. That, if you see, is the organogram of the committee which made the guidelines. And this was what we call the agree-to framework within which the guidelines were framed. And these guidelines actually came out in 2015, and since then they have been updated, and the last iteration of this guideline was in 2023. If you would like to access these guidelines, and if you have a smartphone, please scan this QR code. It will take you to the PDF of the guideline. The guideline is available for free, and if you scan this QR code on your smartphone, it should take you to the website which hosts the PDF, and you can download the PDF and then read the guideline at leisure. I see that some of you are actually doing that, but do please listen to the rest of the presentation even if you have these guidelines downloaded on your phone. These guidelines, in fact, have now been accepted, as you can see here, by ASHRAE, ASRM, the Royal College. So if you go now and search for the Royal College guidelines on PCOD, what you will get are these guidelines. And therefore, during the course of this presentation and in the controversies that I'm going to address in the presentation, and this is the list of controversies that I will address, I'm going to use this guideline as a bit of the final word, because this really is currently the most robust and evolved statement of purpose that we have for the polycystic ovarian disease. So let me begin by talking about ethnicity and polycystic ovarian syndrome. There has been always a lot of thought that perhaps the PCOS, besides being heterogeneous in terms of its spectrum within patients, is also heterogeneous amongst ethnicities. And this has actually been proven for a very long time. Dr. Rohana will remember Dr. P.C. Ho, when he was active in the AOFOG, had convened a meeting in Hong Kong, and I was fortunate to be a part of that, where we had debated about the effects of ethnicity on PCOS. And again, this new guideline seems to say that yes, there is ethnic variation both within the incidence and the severity of how PCOS presents in this world. So in Asians, PCOS seems to occur at an earlier age, is perhaps more prevalent. The metabolic syndrome, is more prevalent. When the metabolic syndrome, it seems to be more severe, and women present for treatment earlier in our region. And of course, all this has implications for treatment, because if there are long-term issues in PCOS, the treatment should be more aggressive and instituted early. On the other hand, implications for treatment of short-term issues is unclear. There is this very, very interesting study which had come out of the UK. You know that the UK has a multicultural population, and that gave these researchers an opportunity to look at IVF outcomes in Southeast Asians compared to Caucasian women. And they had a very interesting finding where they saw that in comparable groups, women of Southeast Asian origin did considerably poorly in IVF outcomes compared to women of Caucasian origin. Now, this should not be used as an excuse by us for poor IVF results, but again, it speaks to the influence of ethnicity. I'll move on now to the diagnostic criteria for PCOS, and it seemed at a certain point that the Rotterdam consensus was firmly grounded in the best evidence. The Rotterdam consensus essentially says that you should either have 2 out of these 3 criteria to make a diagnosis of PCOS. It, however, left out several nuances in the way these criteria have to be fulfilled. And what I'm going to do is use the guideline to fill the gaps within these nuances. Let's start with ultrasound, perhaps the most common way in which you are faced with the diagnosis of PCOD. follicle number per ovary is the most effective ultrasound marker. However, what is the number per ovary which is relevant? And I'll ask you to pay close attention to this. FNPO of at least 20 in at least one ovary is your benchmark for making a diagnosis. I would venture to say that most of the time what we get reported as polycystic ovary are in fact healthy multicystic ovaries. There are really very few ovaries that you will actually see with 20 or more follicles. In fact, it goes on to say that you should always do this by a transvaginal scan. And you know that amongst unmarried adolescents, we can't use a transvaginal scan. And if you're not using a transvaginal scan, you need to combine the criteria of follicular number per ovary along with ovarian volume, which actually causes the benchmark to rise even higher. Moreover, and very, very important, because I'm sure all of us are faced with these very tense adolescents and even tenser mother and father who come from an ultrasound report for pain in abdomen with a polycystic ovary reported on that ultrasound. Remember that there are no definitive criteria to define PCOM on ultrasound in adolescents, and it is not recommended in adolescents. Next time you see the report from a sonologist for an adolescent who says she has PCO based on ultrasound, please call up your radiologist. Don't shout at them, they may not have read this guideline, but at least tell them that you are not supposed to make a diagnosis of PCOD or PCOM in any adolescent based on ultrasound alone. In fact, if you look at the nuance of reporting on ultrasound for PCOS, all these things should be reported on in the ultrasound report. Now again, it's not possible for everyone to adapt this, but it is a useful marker to use as a screening test when you get a report of PCO on ultrasound. Even irregular menstrual cycles, typically again, these worried adolescents and their parents will come to you saying that I got a report, it said it's PCO, and because I have irregular periods, my GP has said that I have PCOD. And remember, this is a very sensitive issue. Women who are told, girls who are told that they have PCOD in adolescence carry that label with them through their lifetime. I've had women coming at 45 years of age with heavy menstrual bleeding and large fibroids. And when I ask them what their problem is, the first thing they say is not that they have heavy menstrual bleeding. The first thing they say is, doctor, I'm a PCO patient. Because somebody in adolescent has told them that I'm a PCOD patient. So remember, irregular cycles change as age increases in menopause. You cannot apply the same benchmark of irregularity throughout adolescence. And most importantly, serum AMH should not be used in adolescence. For God's sake, don't do serum AMH for anybody below the age of 18 unless you're suspecting a premature ovarian failure or you're suspecting some form of ovarian failure. If you then look at how to diagnose hyperandrogenism, you don't really need to do those 17 or 18 tests that are available in the so-called PCOS package, which is given by so many laboratories nowadays. What you need is total and free testosterone. You can calculate free testosterone using FAI. If this is not satisfactory, do androstenedione and DHEAS, but remember, you're not doing this for PCOS, you're doing this for patients who have hirsutism, but have a normal testosterone. Also remember that you are supposed to do these assays using LC-MS or MS assays. The old style of doing assays is no longer considered valid. For clinical hyperandrogenism, the presence of hirsutism alone is considered predictive. What is very, very crucial is the way you make a diagnosis of hirsutism. There is a very, very large variation of hair distribution as per ethnicity in our country. We know that Punjabis and Keralites tend to have more hair growth than people from other regions, and you should always use the modified Ferriman-Galway score, and it should at least be 4 to 6 before you make a diagnosis of clinical hyperandrogenism. When you want to rule out hyperinsulinemia, don't do insulin tests. They are not of any use. The new guideline makes that explicit. Clinically available insulin assays are of limited clinical relevance. What you should be doing is an OGTT using 75 grams of oral glucose, or you do a fasting and postprandial along with HbA1c, recognizing that if you don't challenge the body's metabolism with 75 grams of glucose, your accuracy of diagnosis may come down. So there's no need to do fasting blood sugar with fasting insulin, postprandial blood sugar with postprandial insulin, and I'm saying this because this is one of the most common prescriptions that I see for these patients. For general treatment outside the lens of infertility, what is really recommended is the combined oral contraceptive pills. The new 2023 guidelines make it very clear that you can use the COC even in adolescence. So far we were very careful or wary of using COCs in adolescence because we were worried that they may seal off the epiphysis and retard the growth spurt. But now we know that in the current doses of estrogen that are available, this does not occur, and therefore if an adolescent needs COCs, you should be giving it. It is also now very clear that metformin should not be used empirically. I think at one point in time, you know, there are some people who keep that bowl of candy at reception. I used to think that people keep that bowl of candy and a bowl of metformin, and patients can take both. So many patients used to be on metformin once upon a time. But now we know that that's not really indicated. You should use metformin, but only where there's a metabolic syndrome. Don't use metformin where there's no metabolic syndrome. It doesn't add to anything at all. We now have the option of using the anti-obesity pharmacology drugs like liraglutide and semaglutide, both GLP-1, and you should encourage your patients to use this quite liberally. Remember, however, that if you put a patient on this for weight loss for PCOD, provide them with good contraception. They are not supposed to conceive when they are on these drugs. Inositol is now something which has been accepted very well, and the guideline acknowledges it. The first step of any treatment, if you look at PCOS through the lens of infertility, is of course oral ovulation induction. And the first thing you must do when a patient comes to you with PCOS and infertility is triage them. And you must triage them into non-syndromic and syndromic. The non-syndromic PCO patient should be treated like any other infertile patient. It's the syndromic patient who should first be treated for the metabolic syndrome, and only after being treated for the metabolic syndrome should she embark on a treatment for infertility. There was some concern initially about congenital anomalies and letrozole. We now know that it's not true. And also because of the fact that letrozole acts locally in the ovary without actually disturbing the HPO axis, letrozole results in more monofollicular development compared to clomiphene, which results in multifollicular development. As data has come in, we have now stratified oral ovulation induction. We have stratified it to the extent that if you have patients with high ovarian reserve, then you start with letrozole. If you have patients with unexplained infertility, low ovarian reserve, or normal ovarian reserve, then start them on clomiphene. It doesn't mean that in these circumstances you can't use the other drug. It is what is about the first line of treatment. And if you look at the Indian recommendations, you know that letrozole was briefly banned for the indication of oral ovulation induction. And when it came back, the drug controller says that you're supposed to use letrozole only 2.5 milligram once daily for 5 days. Although that's quite contrary to a lot of evidence and guidelines. You are, according to the international guidelines, you can use letrozole up to 7.5 milligrams for a period of almost 10 days. But our drug controller says 2.5 milligram for 5 days, only for 3 cycles. You're not supposed to use it beyond that. There is really no point in adding supplements. I'm sure all of you are familiar with this. This is a picture from one of my favorite comics, the Asterix comics. I still read a lot of Asterix comics again and again. And Getafix is actually one of my favorite characters. The way he goes into the forest, gets some herbs, and then suddenly Asterix gets a magic potion and bashes all the Romans. And I think supplements in PCOS is something like that. We think we are Getafix, and we are giving all these things to PCOS, where the woman with PCOS suddenly becomes an Asterix bashing her polycystic ovary around. But that simply doesn't work this way, and the supplements don't really work very well. When you're talking about ovarian stimulation with gonadotropins, the take-home message is that if oral ovulation induction has not worked, put the woman on a pure gonadotropin cycle. That is the long and the short of it. Don't combine CC and letrozole with gonadotropins. That actually compromises the cycle. One of the reasons you would want to combine is cost effectiveness, but given the effectiveness of a gonadotropin alone cycle, you would actually be doing the woman a disservice by combining CC with gonadotropin. So if you are going to use ovarian stimulation with gonadotropins in IUI cycles, start with at least 50. I'm not a big fan of the people who advocate starting with things like 25, 35, 50. That will lead to something like 22 days of ovarian stimulation, and both you and the patient will get bored of that cycle, and next cycle I can assure you she will come to me. So if you don't want that, then please start with 50, increase the dose slowly, and be liberal in cancelling the cycle. I'll move on now to ovarian drilling. And this is something which Foxy has recommended for the longest time. I don't know how many of you know, but the first ever Foxy guidelines on assisted reproduction, which is IVF, were drafted by me. And this was way back in 1998. So I had the great privilege of drafting the first Foxy guidelines on infertility along with Dr. Mehru Hansotia at that time. These were actually published in our journal. We'd recommended ovarian drilling at that time. And this is subject close to my heart because it's one of the few papers I had an opportunity to co-author with my father, Dr. D.K. Tang. This was one of the first cohort of papers I had authored on PCOD treated by pelviscopic endocoagulation. I know it's fashionable to run down ovarian drilling now, but remember that there is still a place for ovarian drilling, albeit very, very, very limited. At one point in time, I used to see patients, and it used to be rarity that they had undergone an endoscopy and no ovarian drilling. But now I can tell you that it's a rarity to see patients who have undergone ovarian drilling. The thing is to do careful patient selection, and once you decide that you're going to do a drilling, don't drill more than 4 holes in every ovary. That is quite adequate, and avoid drilling near the hilum. If you do that, you will not land up with diminished ovarian reserve. I'll move on now to the almost last part of my presentation, which is, according to me, perhaps one of the most important advances in IVF. We know that antagonist cycle is now the way to do IVF. But what is most important in an antagonist cycle is the ability to substitute HCG with GnRH agonist to trigger the final follicular maturation. If you look at what happens when you give HCG, the HCG lasts in the body for a much longer time, and the GnRH analog, when used as a trigger, produces a very short and sharp spike. With this, what happens is that the corpus luteum undergoes rapid luteolysis, and because it undergoes rapid luteolysis, you see this miracle which actually has happened, where the incidence of hyperstimulation in patients who have undergone an antagonist protocol with agonist trigger is 0. Imagine with this small change of strategy, you are eliminating the most life-threatening scourge in IVF. And I think that that is worth it. In fact, that is what prompted us in 2013 to completely abandon agonist cycles. So since around 10 or 12 years, I have not done a single agonist cycle in my IVF practice. All our cycles are done with antagonists. And therefore, to paraphrase Shakespeare, to agonize or antagonize, why is it still a question? Shouldn't this safety margin provided by antagonists be sufficient to convince all of us to do only antagonist cycles? And these are the issues. I dare say almost all these issues have already been answered very well. What remains to be answered perhaps is whether programming of cycles with OC pills results in a lower pregnancy rate. I would have to say that the answer right now is it doesn't. If you use OC pills judiciously, and when I say judiciously, what it means is that use it for a minimum of 15 days and make sure that you have a minimum of a 7-day pill-free interval between the last OC pill and the first dose of gonadotropin. Make sure that the patient gets her period in this interim. If you follow this simple principle, you will really not have any problem using OC pills for programming antagonist cycles. So this was the classic antagonist protocol where you would start on day 2 or 3 of menstruation and then give the OC pills. And now we have, of course, this modified protocol, and I must tell you, I've been doing this since close to maybe 22 years now, and it's really served us quite well because we do a lot of batch IVF. Programming is essential. OC pills, minimum 15 days, 7-day interval, and then your normal OC cycle. So the advantage of having a antagonist cycle alone vis-a-vis agonist cycle is simply that in all our cycles in all these years, we have seen that our incidence of OHSS, which needs admission and ascitic tapping in antagonist cycles, is 0. We've had considerably more IVF cycles now, but even in this sample across all our 17 centers, you will see that following the antagonist protocol with an agonist trigger in hyper responders, more particularly PCOS, has resulted in an absence of OHSS. Finally, lifestyle and emotional well-being in PCOS is something we are increasingly becoming aware of and we would increasingly like to address. If you downloaded that PDF, you'll see that the major change in the guideline from 2016 to 2023 is the heavy inclusion of these criteria. I can see, yes, thank you very much. Okay, thank you. This is actually my last slide. And I really like this picture. I'm sure some of you might have seen this earlier, but this is a picture of a baby born to a lesbian couple in the UK. As they write, it was 4 years, 7 attempts, 3 miscarriages, 1,616 injections before this baby was born. And what this couple did was collect each and every syringe and needle. And when the baby was born, they wrapped the baby in the pride blanket. And what you see surrounded in the shape of a heart around the baby are all these 1,616 injections. And this photo is very, very poignant and meaningful to me because it speaks to me very clearly about the effort which patients put in when they fight, combat, and ultimately emerge victorious over infertility. It behoves us to do the best for them, and I'm sure that's what we do. Thank you very much.
Thank you so much, Dr. Jaideep Tank. May I now request Dr. Umayal to present the plaque to Sir on behalf of Kanjivaram OG Society.
So it's a honor for us, sir. வா 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 நான் இப்படி வந்துடுறேன். Okay. Foxy VP Southzone International Conference conducted on 18th to 21st of July 2024 at our Hotel Carlton Samutra, hosted by Kanchipuram OG Society. This plaque is dedicated to Dr. Jaideep Tank, President Foxy. We thank you and are very honored by your esteemed presence to deliver this Mr. and Mrs. Ayavu oration on controversies to census on PCOS on July 20th, 2024, signed by Dr. Madhuri Patil, Secretary General, Dr. Charmila Ayavu, Vice President Foxy, Dr. Chakravarti Sir, Organizing Chairperson, Co-Chairperson, myself, Dr. Umayal Murugesan, Organizing Secretary, and Dr. Vijay Lakshmi, Organizing Treasurer.
Please accept a small gift on behalf of our family. Thank you so much, Dr. Jaideep, for delivering oration. Thank you. Manju. Listen. Thank you so much. Thank you. There's a bag for you.
I immensely thank Dr. Jaideep Tank for the oration. Now we move on to the next oration is by our President-elect Foxy, Dr. Sunita Tandulwadkar. Ma'am, we request you on stage. She is the President-elect Foxy and she has the oration topic of love affair, me and endoscopy. I request Dr. Umayal ma'am to join the chairpersons on stage. I request the chairpersons to take over the session.
Thank you so much. May I now request Dr. J.M. Kannan to introduce the orator, please.
Dr. Sunita, the great knee endoscopy orator, is not only an endoscopist, she's an obstetrician and gynecologist and also a big ART person. Yesterday morning, she cancelled her flight because she had a very important person from Pune to be delivered. And she didn't have food and came here yesterday evening. So she is a wholesome person of reproductive health care. Of course, she has got a Ruby Hall clinic, D.Y. Patel clinic, Solo clinic and stem cells clinic. We are very proud to say that she is the first woman in the world to have produced a stem cell baby on a 45-year-old female in 2018. A big applause for her. On 16th April 2018. And that day she decided that she will also form the World Society of Rejuvenation, which has started in 2023. Of course, she is in endoscopy in a great way, and 2018 she gave us the opportunity to do the National Endoscopy Conference at Chennai, in which myself, Malaraj, Charmila and others were a great part, and we all a lot, and we did a big program there with 3 TV projections, and we had about 54 cases to be done on that day. And I'm very proud that she's not only a humane person, she's a very, very spiritual person, and her connection lives with me eternally with that spirituality. With this, I request Sunita to take over knee and endoscopy.
Thank you.
Ma'am, may I now request Dr. Chakravarti, the President of Kanjipuram Society, to present Madam with a shawl.
I'm liking this. Before oration only felicitate. So whether you give it well or not doesn't matter.
It is an honor that you have come, Madam. That itself is a... Madam, please come on to the stage. May I request Dr. Umayal to present Madam with the oration medal. It's my honor to read the citation for Dr. Sunita Tandulwadkar at the Southcon Fogsi Southzone Vice President Conference when she's presenting her oration on Me and Endoscopy, a Love Affair. Dr. Sunita Tandulwadkar is a woman with a mission. She lives her life in a manner that excellence is becoming a habit rather than a choice in her work. She's an eloquent orator, a popular invited speaker at more than 400 national and international conferences. Madam practices in Pune as the HOD and Chief of the IVF and Endoscopy Unit at Ruby Hall Clinic, and is also attached to the Dr. D.Y. Patil IVF and Endoscopy Center, Pune as advisor and consultant. She's a pioneer in stem cell research and application and has started the Solo Stem Cell Center in Pune with a unique achievement in India's first stem cell baby and the world's first at the age of 45 in April 2018, along with the world's first ovarian rejuvenation procedure in 2023. She is a president-elect of Foxy 2025 and has adorned several prestigious positions in the past, including founder-president of the Society of Ovarian Rejuvenation, president of the Pune Society, president of IAGE, a second VP of ISAR and VP Foxy amongst many others. She's a president-elect for ISAR. Her academic contributions as reviewer and advisor for the Journal of Human Reproductive Sciences have received great accolades. She is a recipient of several prestigious awards, notable among which are IVF Icon for the year 2022, Pride of Foxy in 2020, the Bharat Gaurav Puraskar in 2019, and a letter of appreciation in 2012 from the then President of India, Srimati Pratibha Patil. Dr. Sunita Tandulwadkar represents a woman who stands up for what's right, who chooses to fight the wrong and establish a very strong example. She represents a complete woman, a mother, wife, daughter, and friend at heart, who is always there for her near and dear ones, and who is also a fiery force to stand up the entire medical community in times of crisis, who chooses to do greater good for greater numbers by acting at a macro and micro level. Success doesn't come easy and just receive bouquets and brickbats for tough decisions, which is now part of the journey she chose. A leader by nature, most youngsters look up to her with awe and get inspired with a line of thinking. with a soft core and a tough shell. She's ready to take on the world, and we wish her all the best in her future endeavors. We, the organizing committee members of this conference, are happy that she has accepted to deliver the Southzone Fogsi Vice President oration, Me and Endoscopy Live Love Affair on the 20th of July 2024, signed by Dr. Jaideep Tang, President Fogsi, Dr. Madhuri Patel, Secretary General Fogsi, myself, Dr. Chakravarti, the President of Kanjivaram Society, and Dr. Umayal Murugesan, Secretary of Kanjivaram Society. Thank you so much for accepting the oration, ma'am.
Good afternoon. I am so thankful to Foxy, Dr. Jaideep Tang, Charmila, most vibrant VP. I know Charmila for years, and I know her mentor, Jayam, for years. The way they work, I'm not working with them now. As Jayam said, when I was at IIG, she had organized the most amazing conference, but I want to tell one beauty of that which no one in India, even I can do. As an organizer, Jayam had organized some 60 plus workshop cases. We performed, and in the night, we had a dinner, all of us, near 100 people, at her place, cooked by her. I can't imagine anyone cooking herself. She was continuously working for 8 days to do the preparation in such a way that she can feed us. So thank you for being here. And when Jaideep spoke so high academically, for last 4 decades, how the journey of PCOS, I think mine will be little relaxing and enjoying. It's nothing, it's just my love affair I'm going to discuss with you. So enjoy my love affair with me. Can I have the lights little dim? Thoda light dim karo. To the endoscopy, I talk to my laparoscope, I talk to my endoscope. I want every morning to start being wrapped in your arms. I'm restless if 7:30 I don't have first laparoscopic surgery. If I have to come for a weekend, all my friends know, पहले सुबह एक laparoscopic surgery करके फिर बाहर पड़ो. So was it a love at first sight, or was it a thought process over a period of time? Let's see. My love affair began when the day 1989 I passed my MD and we heard Dr. Harry Ridge performing first laparoscopic surgery. And in government hospital doing thousands of vaginal and abdominal, it was impossible for me even to dream that all hysterectomy can be performed. And as everyone in third year thinks, what next? I was very sure I don't want to be a lecturer, because what I have done in 3 years, the same caesareans and hysterectomies I can't be doing again. And Harry Rich news came. So I was determined to start laparoscopy. Fortunate to have Dr. Rajesh, who is also had same interest. In 1992, I went to the city of Pune. I don't belong to Pune. Now I am a Puneite. I started with level 1, level 2, and it blossomed, the love blossomed to level 4 as the time passed. I just entered in Pune with rupees 1,000 in my pocket. My father was upset, Rajesh ka father was upset, but they were a businessman, and if we take a money from them, we will never work hard. In return, my mom said, my 4-month son, Rishi, you don't have a money for his milk also, I'm taking him. And I allowed Rishi to go to Sholapur, but I did not take a money from them. You need to be there to be different, in a different city. I don't want it to become a subject of criticism, because laparoscopy was not the routine trend of a surgery, especially the laparoscopic hysterectomy. I don't want it to land. If you don't want to be criticized, the first thing is don't land in a complications. And I think that is the way why over the period I became a perfectionist. I don't like even 5 millimeter scar having a wound infection. Now there was no training, neither there was a money to go for training. So every laparoscopic surgery, those were the VCR day, I never knew people in Pune. So the only thing what I used to do is watch your own video and decide how you can be better over the period. Don't land up in litigation should be, and this is a strong pillar of strength. I think we need to be lucky to have a supportive husband who is not supporting at home in the operation theater also. The success doesn't come easily. It's a relentless hard work, strong ethics, genuine honesty, and countless blessings. People told me you will not survive if you just don't communicate with the society. I was not ready for that. I don't wanted elevator. There is no elevator to success. You have to take a stair one at a time. Now the unfortunate story was in 92 to 94, no institute had laparoscope. So I have taken a loan, and even today I have this single chip Lenke camera with me. It's so amazing to have your system. Looking back, I do wonder when you are doing now, since 2015 3D, believe me, I cannot operate in 2D system. I become so restless. So single chip camera, how we used to do, we don't know. I gathered some money to attend one international conference and pre-congress workshop. I attended Anu Vates. I always tell him, I saw you performing TLH and Burj, and that was the reason. And I want to thank here not only Anu Vates, but my medical college and my unit and my teacher, my foundation, because the amount of hysterectomies and cesareans and the vaginal hysterectomy, our list used to be 6 abdominal and 6 vaginal hysterectomies a day, 2 units, alternate days, so many surgeries. So your foundation, your pelvic anatomy has to be good. Endoscopy has given me the gift, recognition as a surgeon. I think before the era of endoscopy, we need to have only 1 or 2 giant people who were known as a great surgeon. Endoscopy, I think, has given me that big recognition, and I wanted to give my journey back. I believe that we all are going to leave, but we need to keep our footprints, and I just donated and raised a beautiful operation theater complex of endoscopy in my own medical college, never knowing that my name will be given in the medical college. And it is, I think, you know, when I read, I feel so honored. You just have to do it because you want to do for this. This is my PG teacher, Dr. Munot. I owe my all success to my teacher who taught me hysterectomies and vaginal hysterectomies and abdominal hysterectomies. Another thing is the generous husband. What I earn, I spend. So I want to donate, I want to develop operation theater endoscopy. It was not easy job, but what I am earning, I can spend, no objection. So I feel government medical college to put up your name for the operation theater is much, much difficult. In endoscopic surgeon, we often face challenges and we need to master them. There are 2 things, advances in endoscopy and with the patients with the pathology. We don't grow when things are easy, we grow when we face the challenges. So don't limit your challenges. That should be your case. What is important is in endoscopy, you need to practice, master your practice, because you need tremendous eye, hand and leg coordination. You are watching on the TV and you are operating. So you need to have tremendous coordination, and that takes some time. Secondly, endoscopy is a surgery of instrument. There were no much instruments available, and so I started designing my own instrument. So endoscopy has made us creative, and even today, now there are so many manipulators in the market, but even today I use my own manipulators, and the fellow who is fantastic, who has done well, I always give them one. Two-dimensional vision is the one which we started, and why it is difficult, because there is no depth of perception in 2D images. You need tremendous coordination for that. But with every passing day, you can't say, I can do hysterectomies, I can do myomectomies, I can do endometriosis. You have to keep on improving in pathologies and keep on improving in adopting the technology. There is no choice to it. And when 2015-16 around, Ruby Hall has taken robotic. I won't say I do robotic routinely for hysterectomies and myomectomies, but I definitely feel tubotubal anastomosis and pelvic floor surgery, the robotic is the best. Over the period I age, robotic, the tremors get down. So probably I may change to robotic, maybe after 10 years, I'm just 60, in a very sweet 60 age. So, but if you see, in robotic, 560 degree your hand moves. Otherwise, your hand can move only 360 degree. In robotics, your movement happens 560 degree. This is my first case. But 7 nights I went with turgid tomato with my robotic sister in the OT, peeling off the skin of the tomato and resuturing, peeling off and resuturing, so that I don't struggle on live patient, because robotic will be all filthy rich. I can't afford to do failures. And this is how, if you see, your hand movements go so perfectly well, it is only with the practice. What is important is selection of cases. These are the principles I followed very strictly, and I make all my fellows follow this. Selection of cases in your early part of a learning curve. Every surgeon should pick up the right surgical technique for right patient, understanding his or her limitations and mastery. And as you grow, your experience increases, your exclusion criteria will decrease, you will start doing considerably either morbid or very large uterus. So all these things will start working on it. So pathology increasing, no problem. If you can do 20 weeks uterus, you can do 36 weeks uterus only. What is important is your own level of confidence. What are the machineries you are going to use? How are your assistant? How many cases you put on that? They don't overcrowd. Now, I don't do any laparoscopy, even 4 centimeter, unless patient gives me a consent of laparotomy. See, your name comes only when not only just the litigation, but patient goes happily. Every day, 5 patients leaving your hospital happily with your name is over the decades will make your name. So very important is don't promise. Always under promise and over deliver should be your strata. I always say I'll try. I can't promise. You need to give me a consent because you will be under anesthesia. So second thing is you will see the whole hysterectomy, not a single drop of blood. So which are the energy sources I'm using are a simple bipolar and harmonic. You don't need a fancy instrument. It is not the instruments which make the surgery safe. It is the use of instrument by the surgeon makes it most safe. 30 centimeter, 20 centimeter, 10 centimeter, 60 centimeter total myoma. I know the morcellation will be exhaustive. This patient traveled all the way from US. She was supposed to undergo embryo transfer in US. Her embryos were ready and she wanted me to do laparoscopically this because everyone refused. My sonologist is a fantastic guy. He told me this is 20 centimeter pedunculated. The other one is 30 centimeter pedunculated myoma. The 10 centimeters posterior wall I don't even want to see at this stage of my practice because I will struggle. So first thing I need to know is my speed of a surgery. Now these pedicles for 20 centimeter will have 1 centimeter vessels. So I will always put the ligature, 1 ligature or 2 ligatures, and then take a cut nearly 1 centimeter on the myoma. Keep a sufficient margin. You will have a blood flowing out from the myoma, that is an entrapped blood. Don't bother about it. It is going to go wasted. What is important is nothing is happening from the uterine side. Once you remove that fibroid, go to the other fibroid. This is 30 centimeter. Its pedicle was very large, 10 centimeter. It's not going to constrict it, but at least the miniature of the vessel will go down. And again, don't work on the uterus, always on the myoma. I will always suture the myomas before I enter for the next myoma. You can see that loose loop also. And now the third myoma with the myoma screw, I'll bring it out. I'll use vasopressin. I was told that this is a very vascular myoma, but that's okay. Now, no way you can work out whether malignant and all. I don't want to go in that discussion. What is important is you remain in a good plane. So the traction and a counter traction is the key to success. What was more problematic for me is this patient gave me consent for laparotomy if I have to do myomectomy. She said, but for morcellation, I'm not going to give your consent. So this is 10 centimeter myoma of mine. This is 30 centimeter myoma, and then here was a 20 centimeter myoma, and we did laparoscopic morcellation for this. 20 centimeter. My patient demanded, when I told her, I'm going to take out this also as a complimentary. One small, you can see subserous. I thought she will be so happy. I said, I'll give you complimentary one more myoma. She was a Google red. She said, Doc, I did not come to you for these large myomas or a small myoma. This small myoma which is subserous inside, I want that to be out. I'm an infertility patient. If I don't conceive, within 3 years, this myoma will grow and you will put me in another surgery. So I am at your doorstep only for that. Now, if you are fast in your surgery, with 20 minutes of a vasopressin action, it is a bloodless surgery. You suture that off. You go to the next myoma. I'm sorry. You go to the next myoma. You can see I'm just using a monopolar hook, and you take out that myoma. Only when I remove these two myoma, I can antivert. The moment she demanded, my one principle is my patient has to go happy. So I gave a call to my sonologist, where is that myoma exactly? He said, take out 2 centimeter down and 2 centimeter left. I removed that myoma here, and then I went 2 centimeter down and left. I could not feel anything. But 30 years I'm working with Dr. Manoj. I just took a blind cut. Believe me, my patient went happily, not for these myomas, but because I removed that myoma. Probably she paid me heavily also because of that. 20 centimeter, 30 centimeter anterior wall. Now what is our principle is, previous night, all my fellows and we all have to work, which is the sequence of a cases, which energy source I am going to use, how I am going to take. So here, if I take a central incision, I need to enucleate so much, and I have to close so much of a depth. We thought, why not to take a U-shaped incision, but it all depends upon where are the cornules. This patient not necessarily will need. So this is one cornu, this is another cornu. So this is what I was demonstrating. This is a white rangoli with the monopolar I take always, because when it is a large, over the period when you are taking the incision, your assistant pushes the fibroid, you can go in a wrong direction. So all the cases we do this white rangoli. So I was explaining, if I take a central, I need to enucleate, while here I'm taking a horizontal incision, and I can just remove the myoma and close down the remaining flap. So creativity is very important, and believe in chasing excellence every day. Even today, 7:30 a.m. I enter as if it is the first day of my practice, because it is the first operation of that patient. I don't go, I have done over 35 years, 10,000, 20,000, 40,000, no way. I go as if it is the first surgery of my day. So pre-operative procedure, we follow absolute discipline. Success is nothing but discipline observed every day. My principles which were there at 92 and the principles at 24 are the same. Only that time I used to have 1 case in a week. Now I have 7 cases in a day. Prepare yourself well before each surgery to excel and establish the diagnosis. I don't like surprises in camera. Very important. I don't like, oh, there was a fibroid, where did it go? There was a cyst. I cannot accept it. I don't like, so any patient all over India, I traveled so much during my election campaign that every day at least 3 patients from Dehradun, from Meerut and all, they are flying just to undergo laparoscopic surgery because these cases were referred by the gynecologist. They have to do sonography again. I will not accept it. Then we explain the treatment. You don't want litigation? Ensure surgical and non-surgical and pros and cons of every patient. Need of a surgery in your case and the alternative method available so that after 2 years, if she goes into any gossip area during her kitty parties, she will not get that knowledge for the first time saying, Dr. Sunita never advised me that. I don't like those words. So I explain myself the surgery. I take a fitness and anesthesia. Very important for me. The team to be decided, and every patient has to have even mediclaim sanction before she comes. Intraoperatively, yes, a thorough discussion with the team is a must. We reconfirm the preoperative finding and make the anatomy normal. Though your sonologist gives you precisely the pathology, you can't imagine his precision. The way he tells me even 2 millimeter seedling is there, he will tell me. But reconfirmation is mandatory, and once you go in, hysterectomy is very simple. 3 pedicles on right side, 3 pedicles on left side. What is difficult is making the anatomy normal. So I will not touch unless I take out, and I don't need a fancy instrument. Simple grasper and a scissor. Avoid using energy sources, fiber by fiber dissection, and you proceed for it. Very careful use of energy. Obviously, I'm not going to show you all the videos. Probably this is all the myoma, compressing 3 myomas from the cavity. I'm very clear, I have explained the patient. I'll remove only myoma, all the 3 if the cavity is not open. If opened once, I'll still go for second. If opened twice, I'm not going to operate in the same sitting. You will land up in intrauterine adhesion. But if I have not explained this to patient, she will say you did not remove 3rd one because you don't know how to remove. So very important. Here another fibroid, and it depends upon many a times the mediclaim what patient has sanctioned it. So if mediclaim is filthy nice, giving me all energy, I can use, this is an NSIL. Being in an institute, over the period, you buy all the machineries because it's very easy. You have to just go to your CEO's cabin and tell him, I have LigaSure has come in the market and I want it. Now if you do so many work, they have no choice. First they will replace you, they will not listen. Second time, if you remain persistent, 3rd time they will do the purchase. So this is the LigaSure I am using. But I want to show you that bipolar, monopolar, nothing. One more syndrome we all surgeon has to be. I think it's okay. I don't like this syndrome. You know, sometimes you are operating and you felt, oh, my bipolar, my monopolar has touched the bowel. Probably it was superficial. It may not have penetrated. I think, let's see later. No, later is a fecal fistula. In 2 minutes, you can just take a stitch and enclose that. So don't have this word with you, I think it's okay. I don't allow, even my anesthetist saying, I think it's okay, Sunita, what are you doing? I said, no, don't tell me. I don't want my patient to come on 7th day with the fecal fistula. My Ruby Hall team will guarantee you in 32 years, I never had any fistulas, not because I'm not operating, but I'm operating with tremendous care. You need to be creative and courageous. Endoscopy has given us an opportunity to be creative. What is important is every night, sit on your table with the pen and a paper. Tomorrow I have this myoma. In what way I will be different? Tomorrow I'm doing this case. Is there any way I want to be different? Design, simulate the surgery previous night as if you are doing, so that we can perform beautifully next day. So rehearsal is mandatory, and this is how now everyone calls it metroplasty. But in 2006, 18 years ago, we received the best paper award for the unicornate uterus because it was so painful in a private to tell that you will have an increasing gestational abortion. Don't worry, this time you reach to 18 weeks now, see positive. Now next time 24, so I prepare her for one more loss. So I sat and thought, what happens with this? What happens is, with every pregnancy, the volume of the cavity increases. So in 2004, I sat with my team, can I do hysteroscopically? Let's collect the cases. We were thinking of collecting 10 cases, but we got only 7 cases in 2 years who had a recurrent abortion with unicornuate. I don't do it just as a routine. They have to have a history of a recurrent abortion. So can we do it? If it is unedited video, unicornu is always your landmark. Your aim is here to convert tubular cavity into triangular. Today I have stem cells. Today I have a PRP to maintain the cavity. That time it was just I had was the estrogens and progesterone, which I knew is not going to create the basal endometrium, but I don't know if the basal endometrium from that wall grows, then I may have it. Submucous myoma, challenging case, 10 centimeter myoma, unmarried girl from Saudi Arabia, you will go and try and do it. I'm not playing the videos because many times you have seen it. 4 minutes to go. So life is not finding yourself. Life is about creating yourself. We have to think that I want my footprints in what are the various ways I can cook it. You don't say it was in my destiny. Work hard to achieve and then say this is how my God has planned my destiny. I think endoscopy allowed me to enter in 2000 into ART, the IVF, and it has given me a recognition as an ART consultant. It was a long journey of 24 years now, but it's beautiful. In between 1 year, I left the obstetrics and I realized high-risk obstetrics is a very important entity. ART pregnancies, we work so hard to get them pregnant, but these patients needs to be closely monitored. Now everyone speak about pregnancies after ART, but that time I was knowing that these patients develop PIH, these patients develop gestational diabetes, these patients have a IUGR, they go in a preterm labor. We don't know many a time the reason for an oligo, when even if immunologically she is normal and she is young. So I started doing, my aim was not just to give a urine pregnancy positive or a gestational sac. My aim as an ART consultant was to give a healthy baby in hands of healthy mother. And I started back into obstetrics. And I'm sure Jaideep does obstetrics, Jaideep does ART, and he will say that ART and obstetric, those obstetricians are doing almost all cases as a high-risk obstetrics. Always think out of the box. Endoscopy has taught me this. This is my love who entered me for a stem cells. I'm sure I have not entered as a gynecologist. Every one of you probably know my story. In 2015 December, Datta Jayanti, my mom was my first patient because she refused dialysis. She was not a candidate for transplant and she was in uremia with creatinine 4.5. The only way I thought is let me regenerate her kidney. And I entered in a stem cell because no one in India was ready to take me. There were 4 or 5, one neurosurgeon, one orthopedician, even to Vinit Mishra I met, you work in AKD, do you do this? He said, not Sunita. I found a scientist and I started my own lab. And then 2015 and 16 I studied only stem cell and I realized the tremendous capacity of these cells. Now 9 years in a stem cells, I am happy to say my son who entered in a preventive health care has won in G20 the best speech for India. First time India got the award. And it was on the regenerative medicine. So today world is accepting. 9 years ago I received a lot of criticism. But when you have a lab, you are creating. I was not knowing who else I should do. My mom is fine, that was my interest. When to repeat her cycle, I was bothered. How long these stem cells will work, that I was bothered. I was reading that, and during that time I saw many publications of ovarian regeneration. And then I realized that I can put in any organ I wish to put in, provided there is some tissue. So you want to put in a knee joint, don't take stage 4 arthritis when there is no cartilage. Do it in stage 1, 2. There has to be a cartilage to regenerate the cartilage. That's how I do ovary. And let me tell you, we believe in intelligent aging or reversal of aging. And I started from 2016, every year, my own stem cells. I do it. I just go in the lab, I take out my bone marrow, I process, and I take IV. And that is the reason why I work 20 hours, because I regenerate my organ. And believe me, many more people are doing this. It's not me alone. So, world's first baby. If you see in this publication, Shreya Gupta name is the first one, because I submitted it as a India's first baby, and I received a mail, can you write a review article? I had 7 fellows. Every fellow I gave 2 years ka compartment to read all the publication of that. Shreya was, last 2 slides. Shreya was the one, very intelligent. She's in Lucknow now, doing amazing work. She read all the publication and she came in the morning, 7:30 in my cabin. Ma'am, I want to tell you one news. I said, why? UPT positive hua tera? Because every fellow is visiting so many poor MH patients that they are bothered about. She said, no ma'am, not my pregnancy. You know what? We have put up India's first baby. If you just add word age 45, it will be world's first baby. Because inclusion criteria of everyone in the world till 2018, if you open up, it was age 40. And we just changed, we wrote to the mail, can we change our headline? They said it is not yet gone also, so you can change the title, because we all know it's very difficult, and by now I have 7+ publication. Endoscopy has given me recognition as an author. It's not only the teacher, but as an author, the first book I received and I played on. The amount of conferences we did in last 2.5 decades is uncountable. And most important thing is, it has given me a recognition as a teacher. So you as an entity has started only because of endoscopy, and that's why my love for it is. True leaders don't create followers, they create more leaders. And I'm proud to say I have so many amazing, great endoscopic surgeon, ART consultant, and obstetrician all across the globe doing work. And also, it gave me a courage to start my philanthropic work, that is sponsor a birth, where my Solo Research Foundation does complete free medication, IVF, freezing, embryo transfer, everything is taken care of. So it gave me a vision to be a philanthropist, because you don't have only rich people or who can afford IVF. You do have many poor patients who are just can't afford IVF, and you feel so much pain. What can I do for them? I can't afford, and then this foundation start. So my heart is and always will be yours, dear endoscope. Last 2 slides, as Jayam has told, it's all my Gagangiri Maharaj, what I am today. I was supposed to settle in Mumbai. I went to him. I said, oh, Jaslok Hospital, my uncle was a medical director. I'm settling. He just looked at me and he said, you go to Pune. I said, Pune, the city I never entered. I don't know the people. I don't know the roads. I don't know the doctors. He said, I'm with you. And I took the road to Pune. But he did tell me, I'm not telling you it is going to be easy. I'm telling you it is going to be worth it. We pray every day morning, 1 minute, everyone, whichever God they believe in. You have a Keralite sister, she can pray Christ. And we all pray, we invite the God. We are the mediator, the God operates, and that's the secret of no complication. If you pray for others with a sincere heart, then you will not need to pray yourself. And I will always thank God for blessing me much more than I deserve. Thank you.
Thank you so much, ma'am. May I now request Dr. Umayal to present the plaque on behalf of Kanjivaram Moji Society. Thank you, ma'am. Thank you so much. Wonderful as always.
It's a privilege for us to present this plaque on behalf of Foxy VP Southzone International Conference on 18th to 21st July 2024 at Hotel Carlton Samutra, hosted by Kanchipuram Society, to Madam Sunita Tendulkarkar. We thank you and we are very honored by your esteemed presence to deliver this Southzone Foxy Vice President's oration on Knee and Endoscopy, a Love Affair, on July 20th, 2024. Signed by Dr. Jaideep Tank, the President Foxy, Dr. Madhuri Patil, Secretary General Foxy, Dr. Charmila Ayavu, Vice President, Dr. Chakravarti Sir, Kanchipuram Society's President, myself, the Organizing Secretary, and Dr. Vijay Lakshmi, the Organizing Treasurer.
Thank you so much, ma'am. Please accept a token of appreciation from us. Thank you so much. From my family, ma'am. Thank you, ma'am. Very nice.
Thank you all. Now we break for lunch.
It will be there. It will be done.
Very good
Sir,
afternoon to
we
all
want
of
a
you.
picture with you.
This is Dr. Sudha from Mysore Obstetric and Gynecological Society. I heartily welcome all of you to coming Eva Foxy, which is going to be held in the heritage city of India, that is Mysore, in the month of August 9, 10, 11. So all of you please come and enjoy our guestship there. And our VP is Dr. Chamila Madam, and thanks sir is going to be there. And there are 10 workshops and many scientific sessions. Please come and bless us and guide us and enjoy the heritage city stay there. And it is in a resort, that is Silent Shores. I repeat, it is in the month of August 9, 10, 11. Thank you.
I request that all of you attend the South Zone Eva Foxy, which will be held at Mysuru. Very well done, and they worked so hard.
We are going to put it right now. It is taking little time. That net is like taking little time to download it. Promo is ready. If you are getting late for the food, after the food we'll put that promo again.
The registrations are there also around 800, Eva Foxy. We request all of you to attend in large numbers and felicitate the conference. Thank you so much.
Kanchipuram Society members, please assemble in the stage. We are going to have a group picture with Tang sir and Ayavu madam, and then we will have a group photo for ourselves.
The sessions will start at 2:30.
Thank you all for joining with the Karnataka team. And Vidya Tobi madam is there, Dr. Bharti madam, who is the president of Karnataka state. She wants to address you.
Congratulations to the Southcon team initially, and then on behalf of the entire state of Karnataka, we extend a warm welcome to all our Southcon members and all the esteemed faculty of Foxy to this very mesmerizing conference which will be held in the royal city of Mysore, which is famous not only for the meticulously done conference, but also for the Mysore Mallige, for the Mysore Park, and the Mysore silk saris, and the Mysore Royal Palace. Definitely you will be mesmerized. Please do make it a point to be there on August 9, 10, and 11. Thank you.
See our beautiful ladies from our society. We need some chairs in front. No time. எல்லாரும் சாப்பிட போணும். No. We will help you.
The sessions will start soon.
chair.
Please have your lunch and come back.
கொடுங்க. ஆமா ஆளுக்கு ஒரு சேர். All of you please move little bit back. So please move little bit back to arrange the chairs. ஆமா ஃபர்ஸ்ட் வந்து பிரசிடென்ட் சார் மேடம் எங்க சொசைட்டி மெம்பர்ஸ் அப்புறம் நாங்க மட்டும் நீங்க எல்லாம் சாப்பிட போய் எல்லாரையும் கூட்டிட்டு Madhuri madam is not there now sir. I think she has left. All of you please join us. We will all have a group snap. Please all of you come on stage. Yeah. The stage is here. Please come. Jay madam, Vanga madam. Come. Please all of you join. Yeah, we will. All of you will come. Then we will have a picture shoot. Illa, we will call the seniors. Sit madam. Yeah, please join madam. Please join. Madam, Mananmani madam, vaanga. Mela vaanga madam, vaanga. Suchitra Pandit madam, please come. Please come for the photo shoot. Madam, please. Anita, Haritra enga? நான் இப்ப உட்கார முடியாது மேடம். I have to organize. இல்ல பேசிட்டே இருக்காது வேலை நடக்காது. கொஞ்சம் மொபிலைஸ் பண்ணணும். Madam, you are Foxy members, please come forward. Please come forward. Yourself there. Vanga, please all of you come. Those Vanga, please come. Please come forward. See, these will be the memories we are creating. So we are creating a memory of the Vice President's conference at Kanchipuram. At Mahabalipuram. Solla marandutta. Vanga, girls, you're all girls, come forward. What are these two doing? Postgraduates, come forward. You are all part of Foxy. Come. Good job, ma'am. Someone should make some noise. Otherwise, now it looks nice. We are all a team. Everybody is there. Naindrava. Brad. Inga paru. My granddaughter, youngest Foxia, she's standing there, posing. Yes. Muthu, you are ready? ஆமாம்மா சொல்லிட்டேன் எல்லாரும் இறங்கிடுவாங்க then it will become an extended affair. So let him take. We are having that A installed, so you can have a click and you can pick your photos. Muthu, quick, quick. We have to break for lunch. Quick, quick. போதும் perfection போதும். Quick, time இல்ல. எங்களுக்கு academic session பண்ணனும். Hey, come, Uma. Rukmani madam, வாங்க. They are all COGS members. So look at the energy. Yeah. See, many have not yet had lunch. Quick. Muthu, come. Enough. Please come. Please. Muthu. Video. See, when video is being taken, we'll all say long live Foxy. Say 1, 2, 3. 1, 2, 3. Muthu 1, 2, 3 sollu. Girls, come forward. Come up. Vanga. All of you, please come. You are all logicians. Please come up.
Look straight. Look the camera, please. Ready. 1, 2, 3. Judges. Alla biggies. Madam, worry about it. And the photo panchikilla angi apda vaai pannirukeenga. Ready. One more. Ready. 1, 2, 3. Biggies. One more. Ellame thumbs up pidilama. Winning thumbs up. Ready. Ellame kai nidinga. One face manikama. Yaru onnu. Ready. Madam, side la paakadinga, yaari paakadinga, camera mattum parunga. Madam. Side. No problem. Ready.
இப்ப கேர்ஃபுல்லா பண்ணுங்க. Be careful.
நான் சாங் போறீங்களா? சின்ன ஒரு மூமெண்ட். இல்ல லாஸ்ட் முடிச்சிடலாம். ப்ளீஸ் கை கீழ. ரெடி. 1, 2, 3. ஓகே, ஒரே வாட்டி அழகா சிரிக்கலாமா? நல்லா லவுடா சிரிக்கலாம். நான் எப்படி
இல்ல, we want an voice ஒரு video on long live Foxy.
ஓகே, இங்க பாருங்க. இப்போ ஒரு வீடியோ வேணும். We need a video long live Foxy. All will say long live Foxy at the count of 1, 2, 3.
ஓகே.
சரியா?
3 சொல்லி
அவங்க தான் கவுண்ட். நீங்க தான் கவுண்ட்.
ஓகே, நான் 3 சொல்லி ஒரு 3 செகண்ட் கழிச்சு நீங்க பேசலாம். ரெடி. 1, 2, 3. இன்னும் கொஞ்சம் லவுடா. 1. பத்தல, இன்னும் கொஞ்சம். அதே மாதிரி சொல்லிட்டு லைட்டா திரிக்கலாம். சொல்லிக்கலாம். லாஸ்ட் ஒன் மோர். 1, 2, 3.
Thank you so much. Sir Jaideep, thanks sir, and Charmila Ayavu madam. You have to remain for one more with our society members. Our society members, what our group snap? Yeah, Sunita. Huh? Sunita madam. With our society members. So all the beautiful ladies clad in our saris, all gorgeous ladies and gorgeous men also, and the Kutti Foxian, all of you come. Huh? Only Cox, only our society members, please. This picture is for society members. Yes, I think yes. Muthu, you can, right. Bhuvana, vada mele. And this lady, come. Hey, all Kanchipuram society members. We have swelled to 134 members right now, sir.
Cogs, come up, Cogs, come up.
Everybody will start dancing. Our members are very dangerous. They will start dancing, please. See, let us all say 3 cheers to Cox. Okay? Stop music. Stop music. Stop music. Muttu. Thank you. Thank you, thank you, thank you. Thank you so much, sir and ma'am, Sunita ma'am, Charmila ma'am for the Cox members, please stay back. We will be having one exclusive picture of our members. So thank you so much. Hey, Shubha, Indra, va?
Cogs alone, wait. You are not moving out, Cogs. Please. Anit. Ma'am, enakku
எனக்கு ஒரு சீட் எனக்கு ஒரு சீட் எனக்கு ஒரு சீட் எனக்கு ஒரு சீட் பவி ஏய் பவி கீழே வடி எனக்கு சீட் குடுறி ஓகே ரெடியா ரெடி 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 காக்ஸ் காக்ஸ் இங்க பாருங்க we have to start the sessions கொஞ்சம் கோஆபரேட் பண்ணா நல்லா இருக்கும் 4 மணிக்கு இந்த ஹால் நம்ம கொடுக்கணும் ப்ளீஸ் லாஸ்ட் பிட் எல்லாரும் அந்தந்த பொசிஷன் இருங்க only long live cogs okay 1 2 3 on count okay இங்க பாருங்க thumbs up இல்ல பாதி பேர் கை காமிக்கிறீங்க பாதி பேர் கை காமிக்கல thumbs up கிடையாது only வாய சேவ்ல long live cogs it's a video okay
கொஞ்சம் கம்மி பண்ணு சார் நடுவுல கொஞ்சம் ரொம்ப ஓகே ஓகே அப்படியே விட்டுருங்க ரெடியா டயலாக் போலாமா ரெடி 1 2 3 ஒன் மோர் சார் தம்ஸ் அப் வேணாம் மேல இருக்கிற தம்ஸ் அப் வேணாம் அப்புறம் மேம்
thank you எல்லாரும் செஷன் ஆரம்பிக்க அந்த
Amala Devi ma'am and Dr. Girija Va to chair the session. Dr. Vidya Tobi ma'am will be joining shortly. Would first play the recorded video. Ma'am, Vanga. Amala Devi ma'am and Girija Va ma'am, please come to the chair ma'am. Ma'am, he's what, ma'am? Okay. She knows, no? Otherwise, I will tell. I have to write a pen, no?
Good afternoon, everybody. This is now a very important session on ethics of reproductive health, and this is the FIGO session on ethics of reproductive health. And with my co-chair, I welcome you all to this wonderful session where we are going to be having three very important talks. One is going to be on unborn fetus. Does it have any ethical rights? And this is from Professor Ansaklis from Athens, Greece. Professor Ansaklis has been a very senior professor and has been visiting India quite often, and he's also the member of the steering committee of the World Justice Organization, and a very person who has not only initiated various activities in the European continent for awareness about women's health, but also he has been very keen on ethical aspects of these issues. So without more delay, we will start. Professor Ansaklis has not been able to come to us, but therefore we'll have his recorded talk. And we are really grateful to him for sending us a recorded talk so that we do not miss on what is his thought processes. So can we start the talk, please?
Ladies and gentlemen, good morning. This is my pleasure to participate in this very interesting conference in India, and also I would like to thank the organizers for accepting the FIGO Ethics Committee to participate in this very interesting conference. And my topic today is about to try to answer the questions: does the fetus have ethical and legal rights? I believe this is a very important question, and I'll try to do my best to give you an idea about the ethical and the legal rights of the fetus. Ladies and gentlemen, the moral, legal and medical obligations to the fetus create a large number of serious legal and medical questions. And the progressively increasing recognition of fetal rights in the field of law, such as property, insurance, criminal procedures, and civil rights, raise questions which are related to the autonomy of mother and the fetus. Acceptance of the concept that fetus does have rights instantly creates great problems and difficulties in the understanding of very serious questions such as: when does human life and personal status begin? Should the viability limit be regarded as a determinant factor of the legal rights of the fetus? And third, understanding the law regarding legal termination of pregnancy. At the end of the 20th century, a great scientific achievement has achieved that the that of creating series of human primordial embryonic cells. These embryonic cells, with appropriate stimuli, can theoretically evolve in all approximately 230 types of adult cells that consist the 100 trillion cells of human body. These cells derive from the blastocyst, a cell structure which is formed 5 to 6 days after fertilization of the egg and before it implants in the endometrium. During the last 40 years, the technology of the primitive embryonic cells developed to such an extent that in near future it is very likely many incurable diseases which threaten humanity be brought under control. Chronic disease such as diabetes mellitus, various cardiovascular disorders, liver failure, including disorders Parkinson's disease, Alzheimer and multiple degenerative disease of central nervous system may be able to treat in the future with the use of these primordial embryonic cells. However, the techniques that transform these cells into possible therapeutic tools are still experimental. Understanding the process of human embryogenesis allows a scientific answer to the question, when does human life begins? An important indeed legal question is whether the ex utero ovum at the time of fertilization is considered a human being. Because of this manner, it acquires the status of a natural person with all the legal rights and derived from it. According to theological and legal views, a human being deserves respect as a natural person since the very first moment of existence. In vitro fertilization with all its extension, technical donor insemination, uterus hosting for pregnancy, raises a wide range of legal and ethical questions in relation to fetal rights. During the Clinton presidency, the United States National Bioethics Committee allowed the research of cryopreserved embryos. In blastocysts, while it prohibited the human embryo cloning research for reproductive purposes. But the most serious objections were expressed by those who support the opinion that the fetus is considered as a human being from the moment of conception, and so during the Bush Jr. presidency, funding for research program with blastocysts were stopped. Of course, the concept that the research of human blastocysts, which would anyway be destroyed, may be considered a feticide and therefore is morally unacceptable, was contraindicated by many scientists, arguing that the expected results would improve the lives of countless patients. Thus, several questions appeared with particular acuteness. When does the human life begin? When does human existence acquire the soul, mind, face, and therefore human rights? And these questions have concerned philosophers, theologians, and other intellectuals for many centuries. Ladies and gentlemen, from approximately 2,000 years, the opinion of Aristotle prevailed, who supported that the male sperm process a special power with which after 7 days is able to transform the menstrual blood into a human being, and later on, within 40 days, into a person with a sensitive soul. According to Hippocrates, the entry of the soul into the male fetus takes place on the 30th day of intrauterine life, while the female fetus occurs in the 40 days. According to Plato, a man consists of two distinct entities, the body and the soul. The body is moral, and servile to the soul, which is greater and immoral. And according to the Old Testament, human is by intellectual and by substance with immoral soul, which lies in the hands of the Creator. Of course, since the scientific discovery of the whole process of fertilization, most today admit that human life begins with fertilization. The views of the Catholic Church are clearly outlined in the introduction to Domus Vitae, where it is stated that the man must be treated as a person from the moment of conception, and his rights to life should be recognized as early as that period. In 1997, at the third conference of the Roman Catholic Academy of Life, which took place in Vatican, it was decided that by the union of the two gametes, a life is being created, and the embryo is considered a living human organism since that moment. The position of the Orthodox Christian Church is formulated supports that the process that shapes human beings in the fertilized eggs, regardless of whether it was formed in situ or in vitro. The zygote is destined to evolve and eventually become a human person. Both the fetus and the adults are potentially human beings at different stages of development. For the Orthodox Church, the principle of life is not negotiated. It does not enter the logic of science to explain this is called an embryo or a genetic material or a fetus in English literature, when the cells of the embryo are indifferentiated and when the main organ of the body have been formed. The Orthodox Church sees all this as an evolution of man in his mother's womb in a similar manner to the evolution at birth until death. Therefore, it affirms and insists on sanctity of human life at all stages of evolution. The human cannot be destroyed, nor to be used as experimental purposes, no matter how noble their goal seems to be. Ladies and gentlemen, today the synthesis and the scientific data, philosophical hypotheses and problems of humanity have become a pressing necessity to that we have deal with the moral rights and social problems that come from the intervention of man in various stages of life. Today, dilemmas concerning the respect of human life from birth to death involve not only biology and medicine, but also other sciences such as philosophy, theology, psychology, sociology, legal and political science, which has approached with this issue from different points of view. There is a fine line between the responsibilities of science and those of metaphysics, and it seems that it depends on the physiological and principles of each of us. Pregnancy is a special case in which the attending physician is called upon to make decisions for two patients, the mother and the fetus, and must find the golden ratio in those cases where the interests of one oppose those of the other. There are several concerns with regards to finding this golden ratio because one of the patients, the mother, has an independent morality entirety with documented rights, while the fetus, the unborn child, there is no, at the international level, as to when it is considered a patient with independent moral entirety. Therefore, by accepting the fetus as a separate person, new questions are created about the personhood of the fetus and its rights. The concept of the fetus as a patient has recently emerged as a major topic of perinatal medicine because when the fetus is treated as an independent patient, it is recommended to apply directed treatment, that is a method of treatment that will benefit the fetus. When the fetus is not treated as a patient, is not directed treatment could be acceptable and ethically satisfactory. Today, no agreement has been reached on when the fetus is considered to acquire an autonomous moral entirety. Some believe that the fetus acquires autonomous moral entity from the moment of conception of the moment of implantation. Others argue about that this autonomy is acquired gradually, while some others postulate that the fetus ultimately never acquires a clinical entity as long located inside of the uterus. However, it seems that there will be no final agreement to implement this issue. A golden intersection to be found between theological and philosophical tradition, something that is difficult to accomplish in the state in the state level, much more difficult on a global scale. Therefore, we would be abandon the effort to accept the fetus as a patient with an independent moral status and turn to an alternative approach which will give us the opportunity, in one hand, to analyze the moral concept of the fetus as patient, and on the other hand, to be able to apply the therapeutic approach to the clinical practice of perinatal medicine. The concept of the fetus as a patient essentially depends on various factors. One such factor is sustainability, which should be perceived with the biological and technological parameters. When an embryo is viable, that is when it has attained the maturity to be able to enter the neonatal period with or without the assistance of technological support, or when it is presented to the doctor, then the fetus is considered as a patient. In fetal maternal medicine, when the fetus presents as a patient, the treatment of his health is justified. An aggressive management includes interventions such as intensive care, intrauterine fetal monitoring with various biophysical testing, premature labor, and cesarean section. However, one should take into consideration the existence of severity of various congenital abnormalities, the extreme condition of premature birth, and the obligation of the pregnant woman. Fetuses with lethal congenital anomalies are considered as stillbirths. Therefore, the treatment in such instances should focus mainly on protecting the mother's health. Choosing how to address the health of the fetus must weigh beneficial effects and moral autonomy as well as the independence of the pregnant woman. The uniqueness in perinatal and fetal maternal medicine lies in the fact that any intervention in favor of the fetus passes through the body and the moral autonomy of the mother. And now, ladies and gentlemen, I come to the third question created by notion that the fetus may have rights. The United States Supreme Court supported that the state's interest in the life of a fetus should be inferior to the woman's constitutional rights to terminate the pregnancy until the period when the fetus is viable. Because only when the fetus has the ability to live outside the womb, from the moment on, abortion is considered a crime. A fetus is not a person under the United States law. Thus, naturally, the fetus is not considered or recognized as a person with independent protectable status, and therefore there is no possibility of compensation for prenatal injuries caused intentionally or by negligence. On the other hand, there has been a decision from another court who will be an express emphasize that the child can and must be compensated to damage from prenatal injuries, because the fetus is not simply a part of the mother, but a special existence. Thus, it could claim legal and inheritance of property rights. Today, ladies and gentlemen, as long as the child is born alive, the state allows the lawsuit from the consequences of prenatal injuries. A significant number of courts recognizes action for tort against the fetus, even in the extreme cases where there was medical negligence before the conception of this fetus. The recognition of the right of the unborn children against the tort of